Hello. Hi. Yeah.
No. All right. So you're ready. Before we begin, we just go through again. So you have 5 minutes to prepare. So another 15 minutes with the surrogate and also the examiner for the last 5 minutes. So I will give a reminder at 2 minutes instead of 3 minutes. And it's advisable if you can go into the concern slightly early before the reminder, but there's no wrong also if let's say you're quite uncertain about history, you want to get a bit more and examine more. So this is will be the template. So we shall start. Is it okay?
Yep.
Sorry. Okay, let's start. Wait, let me just check. Okay, let's start the timer. Your time start now. Okay, 5 minutes is up. Let's start. This is the patient, Madam Susan.
All right. Hi. Good afternoon. I confirm that this is Madam Susan, 54-year-old.
Yeah, I'm Susan, 54.
All right. Madam Susan, I'm Dr. Lee here, one of the doctor in the medical clinic. Today, I'll be asking you some question and also at the same time examine you. Would that be all right?
Okay, sure.
All right. So it actually come to my attention that you actually have cough for the past 3 months. Can you tell me more about that?
Yeah, doctor. I have been coughing for almost 3 months now. So it initially it just started like a mild cough, but subsequently I feel like it's actually a bit wet. And then when I cough, I notice that there is sometimes white, sometimes yellow kind of phlegm.
All right. So initially it started with no sputum. Then subsequently, since when you actually developed having sputum?
Can't remember on and off. It's about
On
three
and
months.
off,
Mm.
about 3 months. All right. And the color of the sputum sometimes is whitish, sometimes is yellowish. How about
Mm.
any greenish sputum before this?
Not that I know of.
Okay. Any blood stain in the sputum?
Oh no.
Okay. Is this the first time you actually experienced such long cough?
Yeah, I mean previously I did have asthma when I was younger, but it wasn't like this, and I'm a bit concerned. Can this be a sign that my asthma is coming back to me?
All right, I will get back to you regarding the concern later after I actually examine you and also ask further history. Yeah.
Okay.
So, do you have any runny nose?
Yeah, I mean I always have runny nose since young. The doctor told me this is due to allergic rhinitis.
All right, I see. Okay. And does you ever notice that there is any specific timing where the actually cough will actually get bad?
Not really. I mean I cough from day to night and doesn't really find anything that can relieve the cough.
Okay. Do you realize that when the weather is very cold or very dusty, you have a frequent cough?
No.
No. Okay. How about do you realize that early in the morning when you wake up, you tend to have more cough as well?
Not really. In the past, when my asthma control is not good, yeah, I tend to get that, especially morning when I wake up. But now I don't feel like my cough is worsening in the morning.
All right. Okay. So how about your is there any shortness of breath as well?
Yeah. I have breathlessness when I tend to walk for a long distance. Previously, I'm a very active person. I can jog in the morning, uh, about 2 to 3 kilometers. But recently, for the past 3 months, I realized that when I try to exert myself, I have a tendency to feel breathless and have to rest to relieve this.
Okay. And can you climb upstairs?
Yeah, I can now, but I need to rest in between. Probably about 2 flights of stairs. I need to rest. Only can continue.
All right. I see. How about any noisy breathing?
No, not really.
Okay. Do you realize that you actually have to catch your breath very frequent when you do some any specific activities?
Yeah, I mean when I do activities like carrying object or walk, I have to breathe slowly. Only then I will feel better.
All right. Any fever recently?
Yeah, I realized that for the past 3 months, this thing comes like on and off and comes and go. I do feel a bit feverish, especially when I rest at night.
All right. How about any night sweats?
Not
You
not
drench
really.
yourself at night?
Yeah, when I have fever, I tend to have night sweat. But if I don't have fever, I don't have that.
Okay, and how frequent is the fever?
Sometimes I mean it comes in like episodes. Sometimes for a few days, then we resolve. Sometimes I take some Panadol, it also resolve. But I mean generally it's not every day. About I would say 3 to 4 times per week.
All right, any change in your appetite?
My appetite is still okay, but I realized that my weight recently has been reducing. I lost about 9 kg
All right, over how many?
over these past 3 months.
Okay, was it intentional or unintentional?
Not really. I didn't control it. It's unintentional.
Okay, how about any change in your voice?
No, there's no
No.
change.
Okay, do you have anyone at home that you live together was actually having a similar problem as well?
No.
Any tuberculosis? Do you know what is tuberculosis?
Yeah, yeah, I heard about this.
Okay, anyone at home actually was diagnosed to have tuberculosis before this?
Not that I know of.
Okay, so Madam Susan, I would like to go through several questions that might not be related to your condition, but it's important for me to get the correct diagnosis here.
Okay.
Okay, do you have any dizziness,
No,
any headache?
no,
Okay, how about any body weaknesses?
no,
Okay, any joint pain,
no,
any joint swelling,
no,
any rashes over your face or your body?
no,
Do you realize that when you actually change in the room temperature or in cold weather, your fingers will turn into different color, like for example, blue, white, or even red color?
no, no,
All right. Or how about any easy bruising?
no.
Okay. How many pillows you use to sleep at night?
I mean, I only use one pillows.
Okay. Any leg swelling?
No,
Any fast beating heartbeat?
no,
All right. Any do you actually have a nausea or any feel like throwing up or and vomiting?
no, no,
Any tummy ache?
no.
All right. How about your water work? Was that normal?
Yeah, yeah, it is quite normal for me.
All right. Just now you mentioned that you actually have asthma, and may I know since what age you actually diagnosed to have asthma?
Yeah, I have asthma about at the age of probably around 10 and used to be quite frequent, like getting breathlessness. But I think for the past 30 years, it has been quite stable. I'm taking two types of inhaler. One is
Mm,
called Serotype.
mm,
It's a round purple thing. I take like
mm,
once, but I mean once one puff each time, twice a day.
mm.
And another one is a salbutamol, and I take it as I need. So recently, when I have cough and also breathless, I thought this is an asthma attack. Probably I take more salbutamol, but it doesn't really help.
Okay. Okay. Any history of hospitalization due to the asthma?
When I was younger, I only received the gas therapy in the emergency, but never really get admitted.
All right. How about recently any history of going to the hospital requiring nebulization?
Yeah, I mean, in these past 3 months, sometimes I went to hospital and then the doctor actually said it is normal, just some flu. So the doctor actually discharged me. The doctor don't think that this is an asthma attack because they listen to my lung and they say this is clear. My lung doesn't have any, noisy breathing or anything.
All right. Any change in your medication recently?
No, no.
Okay. Beside the asthma, do you have for your allergic rhinitis? Do you actually have seek any advice before medical advice before?
Yeah, I also got allergic rhinitis taking the mometasone nasal spray as well. And I also have I think the both my knees is quite pain. I also have this osteoarthritis. Sometimes I take the diclofenac tablets maximum 3 times per day, but sometimes I rarely takes it.
Okay. And do you feel like your actually knee pain is actually worse for the past 3 months?
Not really, has been on and off.
All right. Okay. Any surgery done before?
No.
Okay. Any allergies?
Allergic in terms of food
Food,
or
food and medication.
yeah, yeah, I tend to be allergic to the prawns. That's why I avoid it. But medication wise, not really.
Okay. How about any family history of any asthma?
Yeah, yeah. My mother and my elder sister have asthma as well, and my brother also have eczema.
Okay. Any history of any family history of any lung cancer?
Oh, no, no.
Okay. Do you smoke?
No.
How about alcohol?
I don't think alcohol.
Okay. What do you work as?
Yeah, I'm actually retired. Previously I worked as a office staff writer.
Okay. Do you feel like your asthma is actually worse after you retire or in certain condition?
No, I mean I have retired. Previously, when I work, I hardly ever get any attack for my asthma.
Okay. So sorry, are you married?
Yeah, yeah, I'm staying with my husband and have two kids.
Okay. Any history of any miscarriages before?
No, no.
All right. So I would like to examine you. Is that all right?
Sure.
Okay. Vital sign, as mentioned, SpO2 is 94%. Any
Hmm.
finger clubbing?
No clubbing.
Any flapping tremor?
No tremor.
Any joint deformity? Small joint deformity?
No.
Okay. How about the pulses?
Pulses are good. I mean, as I mean, told you, it's good volume.
Mm. Okay. Next, move on to the face. Does she have any malar faces? Malar rashes? Sorry.
Mm, no rash.
Any central cyanosis?
No.
Okay. Uh, any pallor? Conjunctiva pallor?
No.
Okay. How about the trachea? Is it central?
Yeah, trachea is central.
Any cervical lymph nodes?
As a puppet, there is no palpable lymph nodes over the cervical region.
Okay. Examination of the anterior chest. Any scar noted?
No.
Okay. How about the chest expansion?
Chest expansion is equal bilaterally, but appears to be reduced upper zone and the middle.
Upper zone and middle zone, both side.
Yeah.
All right. Any or percussion? How about the percussion?
Percussion is down all the zone is normal.
Okay. How about auscultation?
On auscultation, you notice that there is a prolonged expiratory phase, not much of bronchi, but there is a fine crepitation over the bilateral upper zone.
Okay, bilateral upper zone. All right. How about the vocal resonance?
Vocal resonance is a bit reduced over the upper zone, but the middle
Okay.
and the lower is normal.
Okay. How about posterior chest extension?
Yeah, it's the same finding. You examine
Okay.
posterior chest, only the upper zone
Okay. Uh, the percussion, posterior chest,
is also down.
down. How about the auscultation?
On auscultation, it's the same. There is prolonged expiratory phase over the upper zone, and there is also fine crepitation heard, but
Okay.
no bronchi.
Any loud T2?
Uh, as you examine for the chest, there's no loud P2.
All right. Okay. Any proximal myopathy?
When you check for the power for elbow as well as the shoulder 5 out of 5. And you check
Okay.
for the wrist extension and flexion is also 5 out of 5.
Okay. Madam Susan, I would like to ask, do you take any traditional medication
Oh, no, no.
or over-the-counter medication?
Not really. I mean, I only take the diclofenac as per needed, but I don't really take anything more than that.
Okay. How about your housing condition? Does your surround house environment have a lot of birds?
No, no.
Okay. How about a lot of dust?
Yeah, I'm very clean person. I make sure that there's no dust in my house.
Okay. Okay. Uh, Recently, do you have any history of any traveling?
2 minutes left? No, I don't travel.
All right, I see. Okay. So, Madam Susan, may I know what is your concern?
Yeah, doctor, do I need to get admitted?
Okay, so basically from the your history and your examination, there are several differential diagnoses actually run through my mind. One of it is actually what we call as a hardening of the lungs. We call it as a pulmonary fibrosis. So there are actually a lot of reasons that can develop into this problem. And for your condition, I think you will need to be admitted because the oxygenation level is only 94%. The normal level is actually more than 95%. And once you will get admitted, we will arrange a set of blood taking and also X-ray to decide whether we need to further investigate what are the other modality needed to further investigate.
Doctor, can this be due to lung cancer? Because I have also really lost a lot of weight recently.
Yes, one of the differential, it could be that. However, of course, your symptom besides the loss of weight, you does not have other chronic symptom, and we still need to investigate thoroughly first before we can come into conclusion that it can be a lung cancer.
Okay, doctor, can this be due to some form of parasite infection?
It could be because number one, you actually have asthma, but so far your asthma actually has been well controlled. And for parasite infection, usually they will actually respond to the inhaler that actually you are using, unless it is other type of parasite infection. Yeah.
Oh, okay. Doctor, do
Mm.
you think this breathlessness and cough is related to my asthma?
I don't think it is 100% related because as mentioned just now, your if you it is due to your bronchial asthma, technically it should respond to the salbutamol that actually you are using, but your
Okay,
symptom actually
all right.
doesn't improve. Yeah.
Okay, time's up. Okay, Dr. Lee, would you mind to
Yeah.
go through the list of differential diagnosis for this patient?
My differential diagnosis for this lady will be an interstitial lung disease because of upper zone and middle zone fine crepitation. Then with the symptom as well. Then
What
it
would be
also
the types of the interstitial lung disease that is possible?
the type that of interstitial lung disease that could be possible. I mean, the causes apical usually will be silicosis, sarcoidosis, chronic allergic alveolitis, or hypersensitivity pneumonitis, or even ABPA, and
Mm,
also pulmonary tuberculosis because patient have fever, night sweat, and also weight loss as well.
okay, any other differential diagnosis other than interstitial lung disease?
My other differential diagnosis will be a pulmonary tuberculosis because this lady actually have the symptom as mentioned just now. And then other possibility will be yeah, actually I can't actually drug induced, even drug induced can.
Mm-hmm. What kind of
Mm.
drug possible to cause these symptoms?
The possible drugs that actually can cause could be antibiotics, for example, nitrofurantoin, isoniazid, and also anti-arrhythmic drugs, and also chemotherapy, usually chemotherapy drugs. Yeah.
How about in this patient?
In this patient, I'm thinking actually NSAID, but the NSAID for her frequent usage possible, but not that common.
Mm.
Mm.
Okay, is there any other differential diagnosis?
Other differential diagnosis, not sure.
Okay, let's say I tell you that the patient went for a blood test within these 3 months,
Yeah.
and the GP actually told her these allergic markers, what we call as eosinophil count, is slightly elevated. What would be the any other differential diagnosis?
Oh, then my other differential could be eosinophilic polyangiitis with granulomatosis, EGPA.
Okay, all right, good. Okay, how
Yeah.
will you investigate this patient?
So I would like to take some baseline blood, for example, full blood count to look at the neutrophil count, total white count, and also eosinophil count per se. Then any evidence of infection, then baseline renal profile, and also liver function test. And then for her, I would like to do a chest X-ray because of to look for the any consolidation or cavitation or even fibrotic changes. Then I would also like to send a sputum for culture and sensitivity and TB workup, sputum acid fast specialized stain, and also sputum TB CNS. Then for if let's say the results of the CT is suggestive of any fibrosis or anything, I will proceed with a high resolution CT scan for her. Yeah.
Okay. Any other blood test that you want to send for? Let's say you're
If
suspecting.
I'm suspecting I mean the EGPA, then I will need to send for a vasculitic workup. Specifically will be a ANCA, P ANCA, and C ANCA. Then I would like to send ANA, ENA as well for her. Yeah.
Okay, sure. How will we manage this patient?
It depends on the diagnosis. If it's for example, if it's a EGPA, then the treatment for this lady will be a steroid and also steroid sparing agent. And it depends on the severity and also the patient respond to the steroid as well.
Mm,
So if doesn't respond to the steroid, then probably she will need rituximab induction, or she will need a lifelong steroid sparing, for example, azathioprine as well. Yeah.
Okay, let's say that what is the negative points against the EGPA in this case?
Her allergic rhinitis actually doesn't actually get worse, and she doesn't her symptom actually doesn't improve with the MDI salbutamol, because if it's really a EGPA, I will presume the asthmatic attack will be very severe.
So do you think this is still possible to be EGPA?
I wouldn't say it's not possible, but it is not top of my list.
Okay.
Yeah.
So let's say the final diagnosis, the most likely diagnosis that in this scenario, which one is the most likely diagnosis?
I will still put as an interstitial lung disease. Number two will be pulmonary tuberculosis.
Okay, sure. And the interstitial lung disease, how about in terms of the management?
It depends on the types and also whether there is a CTD related. So not all, I will need to do a spirometry for her to confirm the diagnosis, and also HRCT, then antifibrotic, and also,
Okay,
for example,
alright.
nintedanib. Yeah.
Okay, okay, that's all. Okay, thanks. Okay, so yeah, a bit tricky, right? This case is not easy,
Yeah.
no? Not easy at all. I mean, it may seem like quite a straightforward one, but subsequently during the history taking, you realize that it's not really related, not really like an acute exacerbation or difficult to control asthma, right? The
Yes.
the surrogate can tell you that the symptom is a bit different, and this actually lasts for quite some time. It's not really have any diurnal variation. It just persists, and getting worse. So
Mm,
yeah, I think you are on the right track. Almost got the diagnosis. In fact, one of your differential diagnosis is already hit the diagnosis. You are thinking that this is an upper zone predominant interstitial
yes.
lung disease, right? And one of
Yes.
it is actually which one of it is actually associated with long-standing asthma and sensitization?
Hypersensitivity pneumonitis.
Or what we call as the chronic eosinophilic
Yeah.
pneumonia.
Alveolitis. Or
Yeah,
pneumonitis. Yeah.
yeah. So
Okay.
this is actually a very difficult scenario because CEP is actually a diagnosis exclusion after you excluded everything. So it's not easy. And this patient, the diagnosis I calibrated is actually CEP, which is a
Oh,
chronic eosinophilic pneumonia, which is same as chronic allergic alveolitis. It's the same thing. But basically, in order to get into this differential, you have to really excluded a lot of things. And in your history, it's quite good. You have excluded a bit on the connective tissue disease, dark history, malignancy, but you didn't ask me EGPA. You didn't exclude about peripheral neuropathy. But for this patient, EGPA is part of your differential. And you actually should also examine for any peripheral neuropathy lah. Huh? So, and this, if you didn't manage to examine, perhaps the history also very important. Whether any head, any numbness, any tingling sensation is very important. And
mm,
you also know that the patient have allergic, strong family history of atopy, as well as the patient also have asthma since young. I mean, usually we know that EGPA is like late onset or new onset asthma, and then eosinophilia followed by the peripheral neuropathy. That will suggest more to EGPA, right?
yeah.
And another thing is that if I think you should actually ask the patient. I mean, I didn't make the scenario easier for you. By right, I should mention the eosinophil count outside the scenario, so it will calibrate the exam differently. But I decided not to do that because I realized that asthma is a very common scenario, and even if I put your significant count is like high, for example, maybe 700, 900. I mean, in a bronchial asthma patient, we are not very surprised, right? But
Yeah.
sometimes you should, in this issue, you should really ask, perhaps not really ask about the eosinophil count, but ask the patient in the past 3 months, have you visited any event and done any
Mm,
tests before? It's actually very important because you need to know what was the thing that was done, because you also not very sure whether patient was given any antibiotic, right, during
yeah.
for the past 3 months. So it's important to know what are the potential drugs, because you also think that some for certain antibiotic like nitrofurantoin can also actually exacerbate the the ILD. If let's say this is ILD, and I think the history part is you need to exclude any high risk behavior. Let's say this is a RVD patient. The hidden agenda is like there's some unprotected intimate relationship. Then the whole scenario will be a bit different already. Right? It can be more to ABPA, and it can more to fungal pneumonia, which also tends to be having fever intermittently, chills, as well as the loss of weight. So it's also important for us to exclude high risk behavior. No? And you asked about travel history, which is good. I thought you almost forgotten it. But when after you examine the patient, you remember to go back and then you ask about the travel history. Another thing to consider is in this kind of scenario, you need to think about parasitic infection, soil exposure. So that's why this something additional that you need to ask perhaps all these have you eaten any fresh food, fresh meat or animal meat or even not fully cooked stuff, any exposure to the soil. Perhaps this will actually try to elicit that you are trying to exclude some form of allergic from parasitic infection. Okay, so it's actually not easy. Um, yes, but you got the most finding, and I'm glad that the first differential diagnosis you put is actually ILD. I was a bit surprised actually, which is good because it's upper zone predominantly fine crepitation. And you only get this kind of diagnosis when you examine the patient, right? From the history, do you think this is ILD?
Actually, initially from outside, I thought it's a CTD, ILD,
Mm, mm,
because of chronicity, lady some more. Then somehow got bronchial asthma. Then also I'm thinking of could this be ABPA
mm.
or could this be but of course I actually forgot to ask the receipt part. If actually I got the eosinophil count, and then I'm quite sure that this is CEP lah.
Yeah, yeah,
Yeah.
yeah. Good. Actually, you are good. You're on the right track. I mean, even if you didn't hit the exact diagnosis, but you're already there. Just the management that, it depends. To me, the critical judgment for the management is still you're still able to score full marks because you know that this is a, but not every ILD is anti-fibrotic. That's the key point, lah.
Yes.
Because we know that UIP, which is more to fibrotic picture subtype. Yes, that is usually tractional bronchiectasis, reticulation. All those things are very chronic, cannot reverse one. So that I mean, the management will be like anti-fibrotic. But sometimes a lot of patients, like for this case, CEP is something very steroid responsive. It is
Mhm.
usually NSIP kind of subtype, in which is an inflammatory subtype. So you can challenge with you should actually trial a steroid, and they usually have very good response to that. And the reason I bring out this case is because recently NEJM also published a approach to pulmonary eosinophilia. And this was actually the diagnosis as well. I mean, the patient also got asthma, allergic rhinitis. And then, I mean, the control for asthma looks like quite okay, but frequent use of inhaler doesn't improve this kind of symptom, in which you need to suspect a bit more. And also important for pulmonary eosinophilia, the workup, but what are the things that you want to send? You mentioned about football count, but you didn't mention about eosinophil count, right?
PBF. Yeah.
Yeah, this
No,
is
no, no. I specific
you
eosinophil,
mentioned.
but I didn't say PBF.
Yeah, yeah. I mean, BBF is just to exclude the leukoerythroplastic picture, but you're
Yeah.
glad that you mentioned about the eosinophil count. And I think is the serum IgE is also important. And
Mm.
parasite serology. Nowadays we send ELISA for a lot of things lah, because those things are very difficult to diagnose. The paragonimiasis, strongylitis, for uh, coccidiosis is actually more to RED immunocompromised age group. Yes, you have always need to screen for TB. And then remember that this kind of patient, you should also consider bronch other than HRCT, because bronch we can send for the lavage.
Alpha.
Yeah, and that can give us more clue. Okay, and in a difficult case, you may consider lung biopsy. But definitely, I will. If I'm you, I won't mention also that because it's something very invasive. I don't want to dig my own grave, and unless it's some like a very diagnostic dilemma, we may consider that. And then the rehabilitate. In terms of management, you mentioned straight to the point, the specific one, the immunosuppression, but you didn't mention about vaccination, right? Lung
Yeah.
rehab, and also avoid smoking exposure if let's say there is. So had to be we had to make sure that always remember about the non-pharmacal part as well to buy some time. And the vaccination I think is important in this case as well. And then yeah, I think the question all actually discussed, which is good. Actually, you did really well in this case, because this is actually not an easy case. I would say, even if me, I would think like maybe ABPA, EGPA, drug induced. Sometimes tropical eosinophilia is also possible, especially in our country. But another thing is that CEP is something that we are usually not thinking because it is something like idiopathic in the sense that associated with asthma and does not have anything like infection, drugs, or malignancy, or even autoimmune disease. But it just happened, and because of long-standing symptom. So this topic is more to pulmonary eosinophilia lah. So what are the approach when you kind of like, let's say the scenario, if I make it easier, I will put the eosinophil count outside. For example, maybe 600 or 800. Okay, so 800 is like 0.8 in the differential percentage, the counts. But let's say this is a pulmonary eosinophilia case, then you need to really think about all these differential diagnoses, which is not mentioned in my notes previously. So idiopathic is something like what we call it can be acute or chronic. Usually chronic, I mean the cutoff is usually uh more than 3 weeks lah, no? For acute and chronic. Chronic tends to be like this, very vague like symptoms. Acute tends to be very severe, and they usually present in respiratory distress. And infection is always important for us to differentiate parasitic or non-parasitic. Non-parasitic TB, mycosis, and also sarcoidosis, or parasitic like ABPA, Loifter because of this Ascaris, common in India, hookworm spongionitis. It can also be due to lung parenchymal invasion like paragonimiasis or hematogenous spread like cystosomiasis in Egypt. So all these are not common. So it's important for this kind of scenario to ask about the traveling history, especially in the last 1 year. Sometimes the parasite infection can be very vague. So must ask the patient, have you traveled recently? Have you traveled recently in the past 1 year? You should ask a bit more detail. But yes, if you ask also, she says she no. The next thing is the cognitive tissue disease and also EGPA. Chest or the older name. Now it's EGPA. So it's also very important. Usually they will have new onset or late onset of asthma, peripheral neuropathy, as well as eosinophilia. Okay. And the next one is a drug-induced pneumonitis. So NSAID, yes, can cause pneumonitis. Usually they cause NSAID-induced pneumonitis. And other common drugs that we need to know sometimes is nitrofurantoin. Pulmonary eosinophilia in the chronic stage can eventually lead to fibrosis, which is the ILD. So it's also important for us to give some differential diagnosis for those ILD drugs. And then and then the toxin part is the chemical exposure. So in this kind of scenario, it's also important for us to look at to explore the history on in terms of the occupational exposure. So this patient is a typewriter, doesn't really go to any chemical industry. So if let's say there is, and especially if firefighter, let's say got exposure to dust or smoke, also associated with this CEP as well. Okay, and the others very rare one is like cancer, IPF, and also Langerhans cell histiocytosis. Generally, how to define pulmonary eosinophilia is when we check for the bronchoalveolar lavage, the eosinophil the eosinophil count is actually more than 25% of the total cell count. So this is already considered as pulmonary. Oh, sorry. Uh, I put it bold here because usually all these conditions can cause eosinophilia, but the significant one we call it more than 25%. We need to suspect for those in bold, which is the CEP, EGPA, tropical pulmonary eosinophilia. These three tends to present as very high eosinophil count, either periphery or in BAL. But this three is the one that you need to make sure we put. And this topical pulmonary eosinophilia is something also depending on the country, probably not very common in our Malaysian setting. But let's say if patient got this, limb edema, elephantiasis, then maybe you want to consider about topical pulmonary eosinophilia as well. Okay. All right. Yo, do you have any question or any comments?
No question.
Okay, right. So
Yeah.
yeah, thank you so much. I think if you're going to mark you, this case is almost got full marks, huh? Just probably the history part just need a bit more extra. But and at the same time, I realized that you take about 10 minutes to take history. I think it's a bit too
A bit
long.
dangerous. Yeah.
A bit too long because the examination part, like we are doing virtual thing, so that's why you can examine like very quickly get the sign, right? But in a real exam, you may need to spend a bit more time. So he should try to really ask a bit faster and also at the same time short those unnecessary question. Okay, so the
Okay.
next, yeah, okay. So the next, who is the next by the way? Okay, Eldon, are you there?
Hi, Jimmy.
Hi, Eldon. So you are ready for the second case?
Yeah, can.
Can So we will start. Wait, before that, let me check my timer. Okay, you'll start now. 5 minutes to prepare. Okay, time's up. Dr. Alden, this is the patient, Mr. Harris. Please start.
Okay, hi, good morning. I'm Dr. Elden here from one of the doctors today. Can I confirm that you are Mr. Harris, 25 years old?
Yeah, I'm Harris.
Okay, I received some letter from your doctor that regarding some problems with your urine. Can you tell me more about this?
Yeah, doctor, I've been having passing on this bloody urine in when I for the past 1 month. I'm a bit worried, doctor. I don't know what happened.
Okay. So I'm so sorry to hear this, Mr. Harris. So hopefully by the end of this session, we'll be able to get a diagnosis and to help you. Is that okay?
Sure, thank you.
Okay. So regarding this passing out blood in your urine, is this something that occurs suddenly?
Not really suddenly, but I mean 1 month ago I never have any blood in my urine. And then I slowly realized that my urine is a bit pinkish. Then now that my urine sometimes when I pass out, it's all flank blood. So I'm a bit worried.
Okay, all right. Um, so you mentioned that initially was pinkish and now it's becoming fresh blood.
Mm,
Any pain during your urination?
no.
Okay, is this the first time this happened to you?
Yeah, I mean I didn't realize any episode in the past.
Okay, so is this on and off, or is this happen every time you pass urine?
I would say almost every time now. Previously it's only on and off.
Okay, all right. Is there any tummy aches?
No.
All right. Apart from this, have you noticed that you go to the toilet more frequently?
No.
No, so okay. Is there any fevers during this period of 1 month?
No fever.
Okay. Apart from this bleeding, have blood in your urine, is there anything else that happens during this time or before that?
You mean pain?
Uh, any apart from the blood in the urine, is there anything else that you experience so far, that you're experiencing any discomfort?
Oh no discomfort. I don't have any bleeding anywhere else.
Okay. Any bruising or is notice any bruise over your hands or legs?
No.
Okay. All right. During this 1 month period, do you have any cough?
No.
Okay. Any more running nose than usual?
No.
Okay. Do you feeling any breathless during this 1 month?
This 1 month not really, but for the past 1 week I'm getting a bit more breathless when I walk for a long distance.
Okay. All right. All right. You notice you are more tired than usual?
Yeah, I think my sister told me that when at home she noticed that I become more pale.
Okay. All right. Uh, you mentioned that there's no breath. Sorry. Is there how many pillows do you sleep at night?
Oh, only one.
Okay. Do you wake up in the middle of the night feeling breathless?
No.
Okay. All right. Do you have any chest discomfort during this period?
No.
Okay. Any vomiting or do you feeling of throwing up?
No.
Any loose stools?
No.
Any difficulty in passing motion?
No.
Okay. Is there any difficulty in your appetite? Is there difficulty in swallowing?
No difficult to swallow.
Okay. All right. Do you have experienced any racing of the heart?
No.
Okay, sure. So I'm gonna ask some questions just to make sure I don't miss things. All right. Is there any headache?
No.
Any giddiness?
No.
Do you notice any funny sensation over your hands or your feet?
No.
Okay, all right. And do you experience any hearing problems or problems with your eyes?
No.
Okay. Uh, During this 1 month period, have you noticed that had any change in your weight?
Yeah. I realized that my weight, I mean, I'm quite thin, but I realized that previously my weight is around 50 kg. Now that for the past 1 month, my weight has become 45.
Oh, okay, all right. Is there any drenching of sweats at night as when you sleep?
No.
Okay. How's your appetite?
My appetite is also reduced recently.
Okay. Have you noticed any discoloration of your skin? Any rashes?
Yeah, I have a lot of this rash when I mean not the rash, some lesion over my skin since I was born.
Okay, all right. Okay. Um, is there any pains in your hands and your feet?
No,
No, any joint pains?
no,
Any back pain?
no.
Okay. So when you were young, apart from these skin things, what other conditions that you have that you haven't tell me?
Oh yeah, I mean, when I was small, the my mother told me that I have some fitting episode,
Mm,
and but I didn't go for any proper follow up. I also defaulted the medication. I was started on some anti seizure kind of medication when I was young, but subsequently this thing never come about, so I never follow under anyone.
okay. Do you remember what medications are you taking now?
I cannot remember.
Okay. Apart from how man, so this fitting problem, is it something very commonly occur or it has stopped long time ago?
Yeah, I mean, I never encountered any fitting episode from young until now.
Okay. And you have not been taking, you are still taking your medications or are you still
No, no, I am not on any medication.
okay? All right. Is there any other medical problems that you have?
Yeah, like I said, doctor, I have a lot of skin problem. I
Mm,
have this. You can see that my
mm,
nose here is a bit. I don't know what happened. It's always like this,
mm,
and I can want to show you as well. You can see there's white patches all
mm,
over my body, especially my
mm,
trunk.
mm,
And this my armpit also. I don't know why it's a bit like a lot of nodules and
mm.
skin tag. Yeah, I'm a bit worried.
Okay, sure, sure. All right. Anyone in the family having similar problems?
My brother, my youngest brother, had seizure also during the baby period,
Mm.
and my elder sister actually has some skin problem like mine.
Oh, okay. All right, all right. Anyone, your parents, do they have the similar problems?
I remember my father also have some skin tags, but not particularly no.
Okay, sure. All right. Um, so are you taking any traditional supplements or medications that you bought over the counter?
No.
Okay. Um, do you smoke, Mr. Haris?
Yeah, I do smoke.
Okay. How many smoking packet of smokes sticks per day?
Yeah, sometimes I take half a pack per day.
Oh, okay, all right. Just want to advise you that smoking is not good for your health, yeah? Mm. Uh,
Okay.
any alcohol?
No, no, I don't drink alcohol.
Okay, so sorry. May I know what you're working as?
I was unemployed at the moment. I just graduated.
Okay, may I know what course did you went into?
Yeah, I study about arts.
Okay, all right, sure. Recently, do you travel anywhere?
No.
Okay, all right. So man, I'm gonna ask some sensitive questions from you. Is that okay?
Okay.
So, Mr. Haris, do you have a partner?
No, 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 no,
Okay. Are you engaged? Are you sexually active?
no,
Okay, sure. Do you have any allergies, Mr. Haris?
no.
Okay. Do you have any pets at home?
No.
No. Okay, sure. So can I just examine you, Mr. Haris?
Yeah, sure.
Okay. Just want to see general appearance is he pale?
He is a bit. I mean, there is conjunctiva pallor.
Okay. So I'm looking at the lesions as above from in the picture. Okay.
Mhm.
Looking at the abdomen, is there any tenderness in the abdomen?
Abdomen is soft,
Mm.
non-tender.
Is there any mass felt in the abdomen?
What kind of mass?
Is there any hepatosplenomegaly felt?
No, there is no palpable liver or spleen.
Okay. Is there any flank mass?
Frank mass, as in.
Is the kidneys blottable?
Yeah, when you ballot the kidney, you realize that there is something over the right side. Seems like the kidney is ballotable over the right side.
Okay. All right. Um, okay. I just check for any renal punch? Is it positive or if examiner allow?
Examiner say you can skip.
Okay. Is there any leg swelling?
No leg swelling.
Okay. Just generally check for the neurology, especially sensation. Is there any impaired sensation over the hands or the feet?
You're checking, for example, pinprick.
Pinprick and light touch, yes.
Okay, pinprick seems normal to you, and the
Okay.
light touch, the perception is normal.
Okay. All right. Any abnormal reflexes?
As I mentioned, you can skip.
Okay, all right. So sorry. Then I just want to hear the lungs. Is there any crepitations heard?
When you auscultate the lungs, it's clear, equal breath sound. There's no crepitation or abnormal breath sound.
Okay. So so this is what I see. I just want to examine the back. Is there any scars or any similar rashes like the ones you shown in the picture?
Yeah, I mean there is this whitening patch over the back,
Mm.
and at the same time you realize that towards the back there is also a lump which is not shown.
Okay, all right. So Mr. Haris, is what may I know what is your concern?
Yeah, doctor, what am I having?
Okay, so after getting a history from you and also examining you, Mr. Haris, so there are a few causes that might lead to your this problem of which is bleeding in your urine. However, one particular concern that I think is quite serious and I think needs further workup is something called tuberous sclerosis, which causes some growth in your kidney. So don't mind this term. So it's basically is a inheritable condition whereby this is there is some it will lead to some growths in certain parts of the body, and it will also cause patients to have higher risk of having seizures like in your case. All right.
But how about my kidney? You know, I'm very worried now that you mentioned that I also have blood in the urine.
Okay, yes. So as I mentioned that this condition might lead to some growths in parts of the body. So one particular organ that will be affected will be the kidneys. So in your case, I would most likely think that your kidneys are affected as well. Therefore, you're having this blood in your urine and these similar symptoms of losing your weight.
Okay,
Okay,
can
all
this
right.
condition be cured, doctor?
Okay, so unfortunately, if this is the case of from tuberous sclerosis and the kidney problem is due to this, uh, there is no cure available. However, if there is growths of this kidney and we need to do some further tests also to see is both or one side kidney affected, and if one of the kidneys is only affected, there is a chance of recovery from these growths that affected the kidney by doing a surgery.
Oh, okay. Do you mean I need surgery, doctor?
If the growths are affecting the kidneys, then yes, I'll refer you towards the urological doctor and the kidney doctor, and they will check you. They will assess you.
Doctor, do I have cancer? Now it seems like very serious now.
Okay. So as I mentioned that this condition that you're having, they will lead to a few growths in your body, and
2 minutes left.
okay, and having cancer will is might be one of the cause that that is leading to your this problem. All right. However, for your case, I will need to admit you to do some tests, do some blood tests, and to check your urine. At the same time, I'll do some scans of your kidney just to make sure is there any wrong in the kidney, and also I like to do some further workup to to evaluate is there any do some blood tests, special blood tests. In particular, we call this genetic testing. However, we would need to sit down and discuss along with your siblings and your parents and see whether this is something to be done for or not. All right.
Okay, doctor, will I get any skin cancer?
Okay. So this condition that if let's say it is confirmed, yes, the growth might affect the skin as well. However, usually this growth that affects the skin is usually not cancerous. Means it's just a benign growth.
Okay. Okay, doctor, thank you.
All right. So Mr. Harris, do you have any other questions for me?
No.
Okay. So I'll be giving you some brochures regarding this condition. You can just have it check it out.
Okay. I think we will stop here because I think we will minus the 1 minute for the examination because you just ask and then yes and no stuff. Okay, so how do you find about this scenario?
Um.
Wait,
Okay lah.
Before that, sorry. 5 minutes to 5 minutes for the Viva. Okay. Dr. Alden, can you run through the differential diagnosis for this patient?
Okay, so after examining and getting history from Mr. Haris, I would think that he might have a renal cell carcinoma or renal hematoma from his underlying condition called tuberous sclerosis. As evidence, this evidence by a history of fits since young, and he has also has hematuria with painless hematuria with loss of weight, and there is a mass palpable over the right side of the abdomen, which is blotting kidneys. He also has signs of skin lesions such as what you call it, port wine stain or what you call it, chagrin patches.
Top wine stain.
Sorry, chagrin patches. That one, chagrin patches. And
Okay, which is not shown in the photo. What else that the patient have?
okay, some neophroblomas, some cafe au lait spots.
Neurofibroma.
Not really sure that the the axillary is axillary freckling. I'm not sure.
Okay.
Okay.
Any other sign that you find in this patient?
There's a hypopigmented patches over the abdomen and the legs.
What does it call?
Uh,
Okay, never mind. What else that you find in this patient?
it's
About this?
hyperpigmented macules over the forearms and the axillary.
Mm-hmm. And you mentioned about this hypopigmented, right? And the
Yeah.
hyperpigmented.
Actually,
Okay.
actually something. Sorry, forgot. I
No
can't
problem. Okay. So okay. You have mentioned differential diagnosis of renal cell carcinoma as well as hematoma. Is there any differential diagnosis in terms of palatable mass for this case?
Okay. He could be due to having a polycystic kidney disease. It could be autosomal recessive as he's unilateral.
Mm-hmm.
Also, it can be due to underlying what you call that vasculitis such as good pastures and also vagus. However, that he does not have any history of call for hemoptysis.
Mm-hmm.
So other differences would be a glomerulonephritis
Wait. Palatable mass for this patient.
or purple mass. Renal cell carcinoma, renal hematoma could be due to polycystic kidney disease, could be due to hydronephrosis by obstructive uropathy.
Mm-hmm. Any other thing?
Mm, Unilateral or bilateral? Sorry, in this is a unilateral, right?
Yeah. Okay, never mind. How will you investigate this patient?
So I'll do a usual routine blood test and full blood count, renal function test, liver function test, coagulation profile, and also I do a urine FVME. If he's having hematuria, I like to do a urine spin, urine for cytology, look for any CAS. Also arrange for ultrasound scan to look at the kidneys. Is there any masses? I like to do an autoimmune workup as well. So and let's say if the ultrasound shows there is a mass, there is a lot of mass or there's known to be a cancer, so I like to arrange for further CT scan of the whole body.
Okay, all right. Okay, how will you manage this patient?
So I manage this patient by using a multidisciplinary team approach. Initially, we're referring to dietitian for high protein diet, for occupational therapies, and also physiotherapies. So I like to
Regards to the mass? With regards to the mass?
okay. So sorry, I'll refer this patient to nephrologist or urologist for further assessment. And probably if there's evidence of cancer or is a unilateral cancer, I like to refer for nephrectomy.
Okay, all right. Is there any systemic therapy that you know of that can help with the mass?
If let's say there is proven to be a RCC, there is some tyrosine kinase inhibitors such as sunitinib. Along these lines, they can help if there is evidence of RCC. Or refer for renal biopsy first before the operation. Sorry.
Wait. Do you biopsy the mass for this kind of, let's say this is you suspecting renal cell carcinoma. Do you biopsy?
Mm, yeah, not too sure. I think
Okay, time's up. Okay, time's up. Okay, how do you find about this scenario?
When I saw this picture, all I said can know, but then I suddenly just blank out.
Hmm.
Then I know that let's say this is a inheritable cause, then will lead to this renal cancers. But all these tuberous sclerosis, they will lead, they are high risk of renal hematomas, retinal hematomas, all those things.
Hmm. So this kind of scenario very easily confused with neurofibromatosis, and you should not mention the sign of neurofibromatosis in this patient. Yeah, so we can go back to the history. Just now when I mean it's a very clear-cut scenario, it's a simple, like straightforward spot diagnosis kind of scenario. Hematuria, looking at this, you know that okay, this is hematuria in PSC, right? So the history part, you didn't manage to, I mean, in terms of the hematuria history, you didn't mention any, you didn't ask about trauma, right? Yeah, at least I didn't hear, you didn't mention anything about trauma. And in terms of endemic symptom, you explore half, but you did not explore whether patient is symptomatic. Yes, you mentioned about, I mean, you asked about exertional shortness of breath, mentioned about pale, right? But I mentioned that no headache, no dizziness. But did you mention anything about postural hypotension, so-called postural dizziness?
Oh, didn't.
And because if you thought about that, then when you examine the patient, other than checking for pallor, you also need to ask the examiner for any. I want to measure lying and standing BP to look for any postural hypotension, in particularly for anemia. Because if it's present, then it's symptomatic anemia also, right? It's important. And the bleeding tendency, yes, you asked about bruises. Yes, I also offer that there's no bleeding elsewhere. But let's say that I didn't mention this, you need to ask in detail. Do you have any bleeding from nose, bleeding from mouth, bleeding from everywhere else, basically? Oh, but you need to ask in detail. Another thing is that this hematuria is a painless hematuria. You did not ask about those pseudo hematuria thing, which is quite common. First is trauma. Second thing is any recent vigorous exercise, any food or drugs that you take recently. I can see that you exclude the GN causes, the infective GN causes, asking about fever and also loose stool and also screen for CDD symptom, which is good. Oh, that one is good. And another thing is that in this TSC patient or even NF patient, you should actually under the social history ask about whether any impairment in terms of their learning. So usually they will have some slow learner because there's some big insult in the past. They may have some slow learner. If you ask me, I would say that actually it takes longer to complete the degree. I just managed to finish the arts. When I was younger, I also got a very poor academic result. So all these are maybe a bit relevant, also supporting points towards the diagnosis of TSC. Another thing is that when you ask about sexual history, I think it's a bit too abrupt. You mentioned yes, I want to ask a question. Then the next question is straight away ask about do you have any sexual partner? Do you have any partners? Do you have any sex? I think it's a bit too straightforward. Probably the gentle way to do it is that I'm sorry that I need to ask a few sensitive questions. Are you involved in any long-term relationship? That's the number one to replace the partner thing. I mean, partner, yes. I mean, there's no wrong to ask about it. It's okay. But usually I try to not mention about sex because in UK they are fine with that. But in our population, even as a surrogate, sometimes they may feel a bit intimidating. So what I usually do is I will mention that do you have any unsafe intimate relationship? I will just mention that because we know that intimate relationship is just sex, but we don't want to mention it directly. If they don't understand that, I will mention okay, yeah. Do you have any unprotected sex? Then I will mention in detail. But usually they understand that I will just carry on because I feel it's a bit more gentle to ask this way, And the examination part, yes, this patient is a spot on diagnosis. You see a lot of things, but you mentioned the sign incorrectly. What is this again? You may be a bit blank during the exam, but now maybe you will remember. What is this?
This
This is
TSC,
not this is not neurofibroma because if this is neurofibroma, then you are talking about neurofibromatosis, right?
yeah.
This is fibroangioma, fibroangioma of or the older name we call it adenoma cervicum.
Okay.
Yeah, adenoma cervicum, especially over the nasal and the malar eminence. And this one is not to try to hint you to the axially fracking. It's not, there's no fracking actually. But what you notice is actually all the skin tag. Again, these are actually all the what we call as a fibrosome pendulum. Skin text is a fibrosome pendulum. This is not neurofibroma again. This is just a skin text. There's no axillary fracking.
Mm.
And the thing is that this is hypomelanocytic patch or hypopigmented patch, right? Yes, a lot of people will mention that this is what we call as Ashriff macules, but actually Ashriff macules is strictly speaking a wood slam examination. So we cannot say this is the Ashriff macule. We just mentioned that this is a hypopigmented patch will we do, or hypomelanonic patch is fine, but we cannot mention it's a Ashriff macule because this was what conveyed by the examiner as well. Examiner are very particular at what the sign that we tell them lah. So they don't want they don't want us to mention about Ashriff. I remember I encountered almost the same scenario. That's why I'm just revising lah. During my mock, the examiner actually asked me, so is this the Ashriff macule? Can you say this is the Ashriff macule? I know that the moment examiner ask you is not lah. You cannot say that this is Ashriff macule. Then the feedback was actually this is a wood slam examination. No, we should not mention that when we see in the bare eye. And this is what you mentioned hyperpigmented because you're scared to mention anything wrongly. So what is this? It's a cafe OLED lah, huh? It's a cafe OLED spot. So this is a cafe OLED spot. So together all this this skin sign as well as patient have childhood seizure. So you're suspecting that this patient have tuberous sclerosis. Okay. So I think it's a very straightforward station, but again, you will realize that a lot of simple case we tend to underperform because we tend to say out something that is not very accurate, and therefore it's important. And I got the same scenario in the mock, and the examiner actually asked me when I mentioned that renal cell carcinoma, I mentioned hematoma, I'm stuck already. I mentioned renal calculi also, although it say it's painless, right? But you have to also mention about other benign causes, right? Renal cyst, angiomyolipoma. Yes, you can mention that can be polycystic kidney as well. Okay, but you should mention about that. And another thing is that it's not the TKI that is useful in the RCC for this patient. This patient actually the sirolimus is actually found out to be useful. Even in the RCC also they have some trials on that. Sirolimus is good for two things. First is that let's say patient has seizure, there is subacute ependymal giant cell astrocytoma. It can shrink the astrocytoma. I saying that if patient have renal angiomyolipoma, which is non-cancerous, it can also shrink the growth as well. And this patient, you need to address the fact that patient is defaulted the neuro appointment and all the appointment, right? So you must mention that need to refer the patient to the neurologist and for seizure and for follow on the seizure control, and especially avoid certain anti-epileptic, because we know that in TSC we cannot give carbamazepine as well as phenytoin. Preferably is still topiramate, lamotrigine, because they usually, when they are younger, infant period, they have infantile spasm. But when as they go along, they may actually get this idiopathic generalized epilepsy. Okay, another thing is the euro. Yes, you mentioned about surgical intervention referral, and you also need to mention address about the derm part, because you mentioned multidisciplinary, but when your management is only the euro only, you didn't mention anything about neuro or derm. So derm for cosmetic purpose, you can also offer referral for laser ablation or resection. And then genetic testing is something that is, yes, you mentioned under the concern, which is okay. And yeah, basically that's it. Do you have any question?
So basically, it's not curable, right? Just tell them that it can be managed by surgery and monitoring kind of thing, right?
But to tell them that not curable is a bit too, I would say, direct. You can say that unfortunately this condition has no definite treatment, and the management goal is actually to symptomatically treatment in the sense of medication to control the seizure, blah blah blah, this thing like that. But I know you want to save time to say that there's no treatment, there's no cure, but it seems like some examiner may feel that you are a bit harsh to the patient. You can kind of like tell them in a different way that unfortunately this is not a curable disease. However, it can be controlled. There's medication available to treat you and control the symptom. You can mention something like that. Okay.
Okay.
All right. That's all. Okay.
Right.
So we'll proceed with the next candidate, which is Paul. Are you there, Paul?
Yes, Dr. Jermaine, yes, I'm here.
Okay, sure. So, before I proceed, I just want to talk about the hematuria thing. So just give me like 2 minutes. So usually for hematuria approach, if you look back at my notes, you will realize that hematuria, we tend to divide into age group as well as pain or non-painful lah. To me, when I prepare my exam, I tend to divide as painless or painful hematuria. But again, I realize that sometimes it's not very helpful. The easier way to do is actually when you look outside the scenario, look at the patient age, and you straight away try to classify that. If it's a younger age like this patient, yes, you want to rule out pulmonary renal syndrome, infectious causes, autoimmune related, congenital causes like Alport, adult polycystic kidney. Don't forget about the HST, which is hereditary. Um, what is HST again? Telangiectasia, hereditary hemorrhagic telangiectasia, and also sometimes sickle cell also can present hematuria. Okay, and I didn't mention about the tuberous sclerosis is because it's under sometimes you need to think of association. This one actually I should also put slash TSC as well. Okay, and if his patient is slightly older age group, you should consider about something cancerous from the upper urinary to lower urinary tract. Can be from the kidney, can be from the bladder, can be from the prostate if it's a guy, and can also be due to infection in the prostate, for example. And for our age group, we need to talk about renal calculi. And if you think that this is a painful hematuria and you think that history is suggestive of renal stone, then you need to know what is the cause. Like for example, is it because of hypercalcemia? Is it because of gout? Is it because of, for example, patient have underlying IBD? So you need to think about oxalate nephropathy causing the renal calculi. You also need to think about drugs as well. And UTI is also something common. It can be painful or painless. And some other rarer causes that we need to think is the IE. Because we know that IE can also have painless hematuria. TB can cause everything, especially TB in the bladder can actually explain why patient may have painless hematuria. And don't forget about bleeding disorder. So we have to, for any patient that come up with bleeding, regardless of melena, regardless of petechiae, or regardless of vomiting of blood, we need to make sure we screen for all the systemic bleeding one by one and exclude the trauma causes. No? So this will be the very simple kind of approach to the hematuria. Of course, I didn't mention the pseudo hematuria part, in which we should exclude like any recent change in your diet. Do you taken any fruits, any juice, and then do you went for any vigorous exercise recently? All those things that can, like myoglobinuria, all those that the pseudo hematuria causes. Okay, so Paul, so if you're ready, we will start 5 minutes. Are you
Yeah.
okay?
Yeah, I'm ready.
Okay, so your time start now. Okay, 5 minutes is up. Dr. Paul, are you there?
Yes.
Okay, so your time start now. This is Mr. Artemis.
Hello, good afternoon, Mr. Artemis. My name is Dr. Paul. I'm the doctor in the clinic today. Yes, I got this letter from your GP that mentioned about your headaches. Can you let me know more about it?
Yeah, doctor. So I've been having headache for the past 3 days now, and it has
Hmm.
been getting worse.
Okay. Can you describe the headache? How's it like?
Yeah, it feels like very throbbing in character. I feel like my
Mhm.
head very spinning, and this headache is really disturbing my life. It's very
Hmm.
painful.
Okay. Right. And does the pain, is it one-sided or one left side or right side? Or
No, it's both side over my forehead.
okay, right. And is it all the time there or does it comes and go?
Yeah, I mean it comes and go initially. I mean
Mm,
this is the third day I'm having headache.
mm.
I mean for the first day it feels like throbbing intermittently, but
All right.
yesterday and today has been persistently pain.
Okay. And if you were to give a score, let's say from 0 to 10, 0 being no pain, 10 being very painful, how much would you give the?
It's almost 7 to 8.
Okay, okay, that's quite serious. Okay, hopefully we can be able to help you at the end of this session.
Okay.
Other than that, right, do you have any other problems like with your eyesight?
Yeah, I also have a bit of blurring of my vision for the past 3 days.
Oh, okay. So that blurring is it one-sided or both
Both
eyes?
side. I think it's
Both
both
side.
side. Hmm.
Okay. And can you describe how is it blurred? Is it the whole of your vision is blur, or is it like one part of it?
Yeah, I think my whole vision is blurred.
Oh, okay. So the blurring is always there or it comes and go?
It comes and goes also, but until
Mm.
today I realized that it's getting blurred persistently.
Oh, I see. Okay. So is there and do you feel that is you can't drive properly, you can't see the road signs?
Yeah, today I feel it's getting worse. That's why I come to hospital.
Okay, I see. And are you getting any double vision?
Not really.
Okay. And let's say if you walk, do you find yourself bumping into things easily or people?
No,
Okay, right. And do you have any weakness in your arms or your legs?
no weakness.
Any numbness?
Numbness. It's more like crampy sensation over my legs, but not really numbness.
Okay, cramping over
Mm.
your legs. All right. And do you have any vomiting?
Yeah, I feel very sick, and
Okay,
I've thrown up actually one time already yesterday.
okay, you vomited one time. And what was the content
Yeah, I just
of
food
the
after I
just
eaten my
food?
lunch.
Right. And do you have any problem with the swallowing?
No,
Any problem with your speech? Is it slurred?
no,
Okay. And do you have any jerky movement of your limbs?
no.
Okay. And are you having how's your appetite? Is it good or
Yeah, my appetite is good. Just that I don't feel like eating much for the past
right?
three
And have
days.
you all right. And have you lost any weight?
No,
Any fever?
no.
Okay. Starting, I'm just gonna run through some questions. It might or might not be relevant. Okay, just to help me to get it to see what is the problem. Do you have any what do you call it? Chest pain?
No,
Okay. And do you have any heart racing very fast?
no,
Okay. And do you have any weather preferences?
no,
Okay. Right. And do you have any shortness of breath?
no,
Okay. And do you have any cough, running nose?
no,
And are you having any tummy pain?
no,
Okay. And say when you had a headache, do you feel that your body feels very your face is flushed? You're having you feel very red.
no.
Okay. Right. Okay, so Ms. Arvin, just want to ask whether you have any underlying or you have any past medical condition.
Uh, I was told that I have high blood pressure in the past but I have been taking this amlodipine and perindopril and also some prazosin from the outside pharmacy. I didn't really see the doctor.
Okay. So amlodipine, perindopril, and prazosin. Anything else?
Sometimes I also take a metoprolol as well.
Metoprolol as well. Okay. Any other medication?
No.
And other than high blood pressure, do you have any other medication? Do
Uh,
you have any other medical condition?
no.
Okay. And you mentioned do you follow up with the doctor for your high blood pressure?
No.
Okay. Do you measure your blood pressure at home usually? Is it
No.
good or
I,
not good?
I didn't measure.
Not too sure. All right. Okay. Sure. And other than that, are you allergic to any drugs?
No.
Okay. And anything runs in the family?
I'm not sure, doctor. But my mother and my father seems healthy when they are around.
Okay. Is there anyone that having high blood pressure or any other thing, problem with
No.
blood pressure or okay, right. Um, Other than that, do you have any how's your urination? How's your passing urine?
Yeah, recently for the past 3 days, I realized that I pass more urine than usual. I have to rush to the toilet to pass urine.
Oh, okay. So is it like a lot of bubble in your urine or
No, no. I feel like my urine feels like a bit diluted, but I
diluted?
don't realize any bubbles.
I see. And are you feeling very thirsty all the time?
Yeah, recently I have to drink a bit more water.
I see. Okay. And do you feel that okay? Are you feel hungry all the time?
No,
Okay. All right. Do you have any diabetes?
no,
Okay. Right. And other than that, do you feel that your hands are getting bigger, or you feel that your feet are getting bigger?
no,
Anyone commented that you look different, that your face looks a bit different than before?
no, no.
Okay. Oh, right. Other than that, yeah. Maybe can I examine you, Mr. Martins?
Yeah, sure.
Yeah. I
What do
would
you
like
want to
to
examine?
check the pulse. Is the pulse any radial delay?
No radio delay.
And is the pulse regular, and is it of normal character?
Pulse is regular, equal
Okay,
both side, and normal
okay.
character.
I would like to look at the palms. Is it like big, straight like hands or no?
You compare your palms with the patient, it's the same,
Correct.
almost the
Okay,
same. Mm.
right. And then is there any okay. So other than that, I want to check the eyes. Is there any halo,
No pallor,
any jaundice?
no jaundice,
I want to look at the face. Is there any protuberant frontal or traumatism or maxillary?
no,
Okay. And is there any skin changes in this patient?
no.
Okay. For any fibromas and those things.
There's no obvious skin lesion.
Those are okay. And I'd like to look at the tongue. Is it dehydrated?
Hydration seems good for you.
Okay. And I will like to check the apex beat. Is it to look for any displacement?
When you check for apex beat is actually at the fifth intercostal space, mid-clavicular line.
I want to listen for the murmurs, any cardiac murmurs.
There's no murmurs heard.
Okay. I would like to examine the abdomen. I want to see whether there's any skin lesion,
No skin lesion.
any organomegaly, hepatosplenomegaly.
No palpable liver or spleen.
I would like to listen for any bruise, like renal bruise.
There's no renal bruise heard.
No renal bruise. Okay. And other than that, I would like to check for any palatable kidneys.
No palatable kidney.
Okay. I would like to also listen to the lungs for any basal crepitations and any reduced air entry.
No, I mean the lungs is clear. Examiner say you can skip.
Okay. Um, Other than that, I want to look for. I want to check the eyes.
Mm-hmm.
I want to check the visual field to look for any visual field defect like any bitemporal hemianopia
Visual field is normal.
is normal. Okay, I would like to check the visual acuity to see whether there's any reduced visual acuity as well.
Visual acuity over both eye is also reduced with the patient wearing on glasses. It's only
Oh,
6 out of 24 for both eyes.
for both eyes. Okay, I want to look for any pupils is equal,
Equal?
any, and then R is I want to look for RAPD as well.
That's not examiner say you can skip.
Okay, and I would like to also do a fundoscopy.
Okay, good. Examiner say you can perform a fundoscopy. What particular thing you want to look for?
I would like to look for any hypertensive retinopathy changes,
Mhm.
like all these loss for pseudo wiring,
Okay.
these button wound spots. Other than that, I want to look for papillary edema
Okay. Okay. All right. And
or
is there
pale
any,
optic disc,
sorry?
or any pale optic disc. Or
Okay.
papillary edema.
Okay. Good. Is there anything else?
Other than that, any what do you call it? Macular edema. It's a bit hard to see.
Okay. Examiner say you can. You're done with the fundoscope.
Okay.
Next.
Right. I would like to check the power generally, just to see any weakness in the power.
Examiner say no need.
Okay. I would like to offer to check the sensory
Yeah. Examiner
for
say.
his legs.
Yeah. Examiner say you can skip that.
All right. So Mr. Artemis, I'd like to ask a few more questions. In regards to this, do you smoke
No.
and do you drink any alcohol?
Occasionally only doing for social reason.
Okay. And how much is that? How every week?
Maybe once every month.
Once a month. Okay. And what do you work as?
Yeah. Yeah, I'm working as a scientist.
Okay.
I'm very stressed at work because currently we are investigating a new drug.
Oh, okay. All right, right. So you are a scientist working in the pharmaceutical.
Yeah.
Okay. Right, right, right. And I want to ask a bit of a sensitive questions, and I hope you don't mind. It would help me to help the diagnosis. Firstly, do you use any party drugs?
No.
Okay. Or any recreational drugs?
No.
And are you involved in any long-term relation or short-term relationship?
Yeah, I'm married with my wife.
Okay, right, right.
2 minutes
And
left.
all right, and do you have any other intimate relationship with other people?
No, no. You know,
Okay.
my wife recently have just had miscarriage, doctor. I'm very stressed and sad also.
I see. Okay, okay. I'm so sorry to hear that. I'm sorry. Do you have any children?
No.
Okay. Mr. Artemis, and what is your concern this time?
Doctor, what am I having?
Okay. Yeah, so Mr. Artemis, I think at the moment there's a few possibilities. There could be that can explain your condition. So first thing, your blood pressure is very high, you're having headache and some blurry vision. So at the moment, it could be due to some hormonal causes that causing your high blood pressure, and we will need to admit you and also to control the blood pressure, and also to further check is there any hormonal problem to this. Yeah.
Doctor, what kind of hormonal problem you mean?
So it could be problems with that comes with your one of the glands above the kidneys having produced too much hormones for you and causes high blood pressure. And it could be other problems could be the kidney itself having the vessels in the kidney having being too small and causing blood pressure being high. Other than that, you could have other problems that we need to check. You might have maybe there is a growth in your somewhere near your brain, and we'll need to do a scan of the brain to see whether there's anything like that.
Doctor,
Can I ask?
can this be due to stress? Because recently I'm a lot of stress.
Before we say it's stress, we will have to make sure there's no other condition first. Like I said, we have to admit you and check.
Okay,
Yeah.
time's up. Okay, thank you. Thank you, Dr. Paul. So can you run through the list of differential diagnoses for this patient?
Yeah. So for this patient, I'm thinking about he could be having because he has hypertension and headache and blurry vision with hypokalemia. My differential diagnosis will be one of it is Conn's syndrome, primary arterial syndrome. Other possibilities will be renal artery stenosis, although I didn't hear any renal brief. In regards to his, he also has symptoms of polyuria, polydipsia, that could suggest diabetes insipidus kind of problem as well, and there could be some pituitary causes of his hypertension.
But what kind of pituitary symptom or sign that you explore in this patient?
So so far actually I could have asked more about hyperlactation and also his sex hormone and all these things. Yeah, so I didn't manage to ask all of that.
So
But,
you have
yeah.
mentioned that this can be Conn's syndrome.
Yeah.
What would be your full diagnosis in this patient?
I think this I think he could be having Conn syndrome, possibly Conn syndrome with diabetes insipidus, as he has chronic hypokalemia. It can cause diabetes insipidus.
Okay, all right. How will you investigate this patient?
I would like to investigate him with firstly to admit him to address to control his blood pressure and also correct his hypokalemia. And I would like to send further workout for his to look for secondary causes of hypertension and look for example thyroid function test. And I would like to send serum cortisol, renal serum cortisol, throughout Cushing's syndrome, and urinary cortisol as well. And I would like to send urine FMME and urine for potassium to look for high urinary potassium. And also I would like to send the serum osmolarity and urine osmolarity to look for diabetic insipidus to see whether it has.
How would you confirm the diagnosis for Conn's?
I would like to then plan for angiotensin ARR test, aldosterone renin ratio test to examine for his.
Do you do the test immediately?
No, we have to correct the hypokalemia first, and if the potassium is more than 4, and after that we have to stop all his antihypertensive and change it to I have to stop his metoprolol, this amlodipine, and then plan a later date for his AR.
Is there any other test that you want to do?
If say he's confirmed to have ARR is positive, then I would like to do a saline supplementation test to confirm the diagnosis.
How about localization?
Localization, I would like to do a MRI adrenal, bilateral adrenal to look for any adenoma or in the adrenals.
MRI. Okay.
Sorry,
How will
I
you
think
manage?
CT adrenal, adrenal.
How will you manage the patient?
I would like to address his correct his hypokalemia, and also to change his to optimize his antihypertensive medication, preferably using prazosin and verapamil so that we can plan for ARR. Other than that, I would like to exclude other causes that I mentioned just now. For example, if he's suspecting to have diabetes insipidus, then we need
How
to.
will you manage the patient for Conn's syndrome?
Oh, okay. I would want to refer to an endocrinologist for further treatment. And if we have localized tumor, let's say it's unilateral adenoma or causing the primary aldosteronism, then we can actually refer him to a endocrine surgeon for resection. If it's
If it's bilateral, then
bilateral, then we'll just have to start him on mineral corticoid, okay? MRA, spironolactone. Yeah.
okay, good. Yeah, how do you find? Oh, yeah, let me just stop the timer. How do you find about this case?
Yeah, I think I get some bits and pieces, but I'm not sure whether I can piece it properly because yeah, I'm not too sure whether, and I think my differentials are not enough.
Actually, I think your sheet taking is good. Your knowledge is also good. It's just that I can see that your flow is perhaps not very smooth, and you're stuck here and there in a sense when you answer the examiner question because you need to be very clear and very fast, especially very concise when you answer the question. When the candidate, when the surrogate actually asks you about concern, what do I have, right? You say that this can be any growth that actually causing abnormal hormone production and then can cause high blood pressure. But I mean, you don't have to really talk about the differential diagnosis because the differential diagnosis can leave it to the discussion with the examiner. But because if you do that, then the candidate, the surrogate don't have enough time to ask you other concern.
Oh yes.
So you must try to answer the surrogate concern as short as possible. At the same time, you should address the emotion. So I mentioned that my wife for that scenario just had miscarriage, right? Yeah, you said okay. Very sorry to hear about that. Perhaps you need to be a bit more empathy. This is just to test whether you are aware. I mean, everyone is stressed in exam, but please be sure that you perhaps to tune down a bit and then you should tell the surrogate that very sorry to hear about this. I can see that you are in a lot of stress and now particularly your blood pressure is very high and we need to talk about admission. Are you okay with that? I mean, you just need to go through just 1 or 2 sentences like that, okay? Another thing is that I think your history is okay, but the examination, I would expect you to really perform gao for this kind of case because it's a case of young hypertension, right?
Yeah.
How old is the patient?
36.
36, right? So it's a case of young hypertension, and when you examine any patient with hypertension, especially young hypertension, before you even touch the patient in terms of pulse, right, you should actually offer to check for forelimbs blood pressure. This is a standard. So you must mention that you have to tell the examiner that I want to check for forelimbs blood pressure, look for any differential blood pressure. Examiner say no differential, then you proceed. Then you want to feel for the pulse. For both pulse, especially the brachial, is there any discrepancy? Examiner say no, then you proceed. So it's a very temperate thing. You need to mention this before you rush in to touch the patient. Because you know that young hypertension, if this patient have neurofibromatosis, then you want to rule out coarctation, you want to rule out feel, and you want to rule out artery stenosis, right? So you can follow almost the same approach because the young hypertension, you want to rule out all these things that can commonly occur. Another thing that you should offer is if the patient is a bit obese, you want to mention that I would like to request for patient BMI and also neck circumference because we know that OSA can also cause young hypertension. Okay, so when you examine the patient, yes, this patient had very significant history of early admission, right? So you are expected to really offer fundoscopy early after you examine the vision, right? You're concerning more to yes, you can do a H test for the whether there's any ophthalmoplegia. Next, you want to look for example, you want to look for visual acuity, not wrong because patient have blurring of vision, you should do. But to me, the vision, the visual field is not particularly important. But you want to do is okay because you're not. I mean, there's no sign or symptom to really suggest any central pathology, right? Okay, so perhaps that one I may choose to skip if I have not enough time. But fundoscopy is something that I definitely want to offer. And if examiner say proceed, that I have to do no choice. But this is something that you need to offer in every patient with blurring of vision. Okay. Another thing is that you examine the heart, which is okay. You want to listen for any murmur, and let's say patient have weakness or anything, then you should also offer look for any carotid fluid. Another reason to listen for carotid fluid is you don't want to make sure that this is not Takayasu arteritis. In which Takayasu arteritis can also have carotid fluid as well, on top of the renal fluids. Okay. And yes, abdomen is very important for young hypertension. So you should examine for any mass, especially dilatable kidney, and as well as a renal bleed. And this kind of scenario, you should, under the examination, offer to do a urine dip, bedside urine dip, to look for
Urine dip,
dysuria or hematuria. Because it's a hypertensive nephropathy, it can also occur. You want to look for complication because now that the patient already have blurry vision and high blood pressure and headache, right? You want to make sure that this is not hypertensive emergency. If it is hypertensive emergency, right?
Yeah.
Yeah. So actually, the full diagnosis when examiner asks you, tell me about your diagnosis, and some examiner they are a bit particular. They want the full diagnosis. When you mention a full diagnosis, when we work in hospital, we will mention everything about full diagnosis, but and exam we will forget about this. So your full diagnosis is actually hypertensive emergency, secondary to a primary hyperaldosteronism or Conn syndrome. Okay, and the polyuria and polydipsia can be due to symptomatic hypokalemia. You don't want to mention as a nephrogenic DI is okay. You don't have to mention about DI. So you can just mention that it can caused by the symptomatic hypokalemia as well. Okay, so you should mention about that. This kind of scenario, another thing is the stress that is quite important to mention because patient got a lot of stress factor, scientists work stress at work and also wife with miscarriage. Another thing is that yes, you want to exclude all the other causes of young hypertension. So, but you didn't. So in just like BCC for CC, I think we got more time. But again, in for investigation, when examiner asks you, you should mention the investigation to confirm your diagnosis first. So you should mention investigation to confirm diagnosis, followed by investigation to exclude your differential. So I would mention for this kind of scenario, straightforward one, because potassium is low, high BP like that, I'm kind of like very sure already. So I just mentioned that I want to take a renal profile, repeat the renal profile again because the result shows hypokalemia, and also take a blood gas to look for any metabolic alkalosis. And you want to measure, you want to offer about this ARR test if patient is not actively on antihypertensive, but usually it can be arranged later on, not urgent. And you also need to take a urine dip as well to look for any proteinuria. Yes, in terms of I mean you want to quantify lah. And excluding differential, you can do the thyroid function test. But I remember you mentioned something about AM cortisol, right?
Yeah.
Yeah,
I
but
mean,
AM cortisol-
random cortisol.
Oh, sorry, random cortisol. The justification is
Just part of the the secondary hypertension workout.
you're talking about adrenal insufficiency, or you're talking about Cushing?
Oh no, Cushing syndrome.
Yeah, Cushing by right, we should not use any random, even like early morning, right? It cannot use Cushing, right? I mean, Cushing, we should not
Midnight.
mention about random cortisol. Like. Cushing, you must mention about, when you screen for Cushing, then you can mention about overnight dexamethasone suppression test. You can mention about late salivary, late night salivary cortisol level, or you can mention about 24-hour urine cortisol. Even you cannot just mention a random cortisol. It doesn't.
Okay.
It's not specific and doesn't helpful. Okay, you should mention a more specific thing. So for this kind of scenario, usually endocrine, if it's very obvious, I'll mention a few things like for screening test, I will offer this, and then for confirmation test, I will do this, and then for localization test, I will do this. I will mention about that. And to look for complication, I will do this, and to exclude the differential diagnosis, I will also order this. So, I mean, it's easier for you to mention so that you don't have to, follow the approach like for basic tests, this and that is, and also important. Just now for Eldon, I didn't mention is when we mention about a test, it's not important to just mention a test. It's to mention the rationale of the test. We can mention that RB, FVC, core everything, but we didn't mention the justification. Some examiner doesn't like it. So you need to mention that you want to take a RB, VBG to look for metabolic alkalosis and hypo-K, for example. You want to mention this and that. And CT adrenal is the gold standard, not the MRI. And
Right.
confirmation test, yes, saline suppression test. So for management, you want to mention about MDT, education counseling, and it's important for you because you are short of time. When you mention about management for this patient, right? So you should straight to the point. It's either medical or surgical, right? So if it's a bilateral and patient unfit for surgery or refusal of surgery, then you can consider MRA. However, if it's a unilateral, you can consider referral to an endocrine surgeon for unilateral removal or resection, like you mentioned. Okay, so it's important to keep it simple. And then if you got time, then only you remember you mentioned all those a bit non-pharmacal thing or less important thing, like advice on the low salt diet, and then strict control of the blood pressure, buying the blood pressure cuff, in which the patient don't have any cuff or not under any proper follow-up. So you can see that actually, I got one last question that I didn't manage to ask you, which is why my salt level is low. Oh, the doctor told me my salt level is low, but why? But I mean, you kind of like explain it in the beginning, but if the patient asks you in particular, you should explain that again. Okay. So,
Right.
okay. Any question or any feedbacks?
Hmm. Yeah, I mean, agree with your feedback. I think it's
Yeah,
the
I mean,
timing.
young hypertension is really important. And do you have my notes on this young hypertension?
Yes.
Yes, right. So you must know that young hypertension, we need to be fast lah. You go by weight, any weight change in terms of gain or lose or no change. So this patient have no change in weight, one. So you know that no change in weight is a bit more things to ask. But if your patient have weight gain, you're thinking more to endocrine causes. If female, then something extra like pregnancy lah. But generally weight gain, you're thinking more to endocrine cause. Can be metabolic syndrome, can be hypothyroid, Cushing, acromegaly, or OSA. And if it's a weight loss, it still can be endocrine syndrome, but you need to rule out autoimmune as well as vasculitis. Okay, so Takayasu tends to be a bit common in exam. I mean, for every diet here and there, different center may have one Takayasu. A bit scary, but something that we need to think of, especially dealing with young hypertension and rheumatoid condition or chronic disease that can actually cause young hypertension, particularly systemic sclerosis. Okay, causing the scleroderma renal crisis. Pheochromo, yes, particularly in regards of neurofibromatosis or even without neurofibromatosis. And hyperthyroidism is possible, weight loss. And renal causes is important, especially there is no change in terms of weight. So you want to go out GN, renal artery stenosis. Again, because of GN, it's important for you to ask about, you asked me about frothy urine, I remember. You asked me about a bit of nephrotic kind of picture, but you didn't ask me any blood in the urine, if I'm not wrong. So it's something also important when you ask in the history, you should ask about that. And family history is important because you want to rule out there's any congenital causes like adult polycystic kidney, or even like neurofibromatosis, von Hippel-Lindau, TSC. Alport syndrome is also important. The additional thing is to ask about any hearing issue, no? And Crohn's is definitely important. Usually they may not have muscle weakness, they may not have muscle numbness, but they will have some cramping. So it's also important to ask about cramps. Sometimes they may not have proximal muscle weakness. They may just have some tiredness. And coarctation fail is also important. And the other things is like drugs, calcineurin inhibitor in post-transplant patients, for example. And then OCP, a lady with OCP, and then usually may not be that straightforward just because of that. And young hypertension is also important for us to ask whether patient takes regular coffee, or even elicitor. Elicitor you ask, I remember. But coffee is something we tend to forget about those habitual thing, which is kind of like important. For example, a scenario of palpitation, a scenario of high BP, we could always ask about habitual thing, like for example, caffeine, it's important. Okay, so that's it. Next one perhaps before the next one is the something about PA. This is like a repetition. I have discussed today cases. Most of the today cases are actually from the previous earlier BCC cases that I decided is important to go through, and that's why I'm repeating again. So you can see that this is the approach based on the Endocrine Society 2016, right? Those that at risk suspected use ARR to screen, but ARR, the criteria like what Paul mentioned is correct. Need to make sure that the potassium is normal. At the same time, the drugs withholding, but we need to know this, and some examiner may test us. If let's say non-dihydropyridine cancer channel blocker like lutetium or verapamil, hydrazine, or alpha blocker peripheral acting like pyroxine has minimal effect. Okay, but those you don't remember either 0, 2, or 4. 0 mean no need to withhold, right? 2 is like you need to withhold at least 2 weeks, and 4 is like 4 weeks, right? So 2 is those that ACE and ARB or renin inhibitor very rarely used, but amlodipine is considered as 2 weeks. Okay, so you have mentioned that A and C lah in a way. Okay, the A including the central acting alpha blocker like beta dopa, A also including ACE, and C is the dihydropyridine. The non one don't need to withhold. And then 4 is actually the D, the diuretics, which is the MRA and as well as the all those diuretics basically. Okay, potassium wasting diuretic is the furosemide, the loop diuretic. Okay, so you can mention you to make it short and simple. Just you can remember that we always remember when we treat the patient with PA, we tends to give the prazosin, we tends to give the non-dihydropyramide and hydrolyzine sometimes. So we know that this will not interfere much. Okay, you can see that beta blocker is not in the list because beta blocker, those IVI, they doesn't really interfere much with the test. Okay, beta blocker doesn't really interfere, but as compared to the ACE and ARB as well as the MRA, they can affect the perfusion. Therefore, it will interfere the test. However, we still can interpret the test. You know, there's in a way, if you give the ACE and ARB, and if it's like the test is positive, it's still indicated because sometimes this can be some form of stress test, huh, to suggest whether there's any to stenosis. But okay, so you mentioned that 2 is the A and C, and 4 is the D lah. This is how I usually remember. So let's say it's confirmation screening is positive, confirmation part is basically adrenal CT. Okay, there is a few criteria that doesn't require uh screening test if the patient potassium is very low and renin is very low and the aldosterone is very high, doesn't need criteria. And if another reason is if the patient not keen for anything, refuse everything, so conservative, just treat with MRA. But if you want to confirm, by right, the gold standard is adrenal CT, not ultrasound abdomen, not MRI. It's the adrenal CT. Okay. If the surgical is desired, yes, then you need to do a adrenal venous sampling to see whether it's a unilateral or bilateral involvement. If it's a bilateral, then unfortunately only MRA. If it's a unilateral, then you can do a nowadays you can see that the gold standard adrenectomy is laparoscopic instead of open. Unless there's technical difficulty, then you have to go for open. But you can see that this is what written in the guidelines. This is what we label as gold standard. Okay. All right. Next case is Benjamin. Benjamin, are you there?
I am here. Can you hear me?
Yeah, good. Your voice is
All right,
clear.
sure.
So you are okay.
All right.
We'll start 5 minutes for preparation. Are you okay?
Yeah, that's fine.
Okay. Let's start. Okay, time's up. Dr. Benjamin, this is the patient, Mr. Ahmad. We start.
All right, sure. Hi, good afternoon. Am I speaking to Mr. Ahmad, 45 years old?
Yeah, I'm Ahmad.
Hi, my name is Dr. Benjamin. I'm the doctor here in the medical admissions unit. I've been asked to see you today because of concerns about your blood sugar. But before I start, why you've come in today?
Yeah,
Hello?
so doctor, I've been referred from my GP because
Mhm.
I'm having difficult to control sugar. Doctor, I'm already known to have diabetes for almost 10 years
Mhm.
now. I'm already taking insulin. I usually takes
Mhm.
about Actrapid 18 units 3 times per day, as well as the Insulatard 24 units at night. But I'm very compliant to this insulin injection, yet my sugar is still very uncontrolled. It gets about,
I see.
sometimes it's actually more to 15 to 20 pre-meals.
I see. All right. Well, I'll try and see what we can do today. I'll speak to you and we'll see whether we can get to the bottom of this. So can I just ask, you've been having problems with your, all right, can I just have a look at you? All right, thank you very much. Okay, can I just ask a few questions? Have you experienced any problems with your health so far, apart from this issue with your blood sugar?
Yeah, doctor,
Specifically,
I don't know
go
because
on.
recently I feel for the past few months I've been feeling a bit tired easily. I can walk, I don't have any weakness, but I feel generally my body is not as healthy as it was when I was younger.
I see. Can I ask, when you say that you're feeling tired, does that mean that you feel your energy levels are lower?
Yeah, sometimes I have this headache when I wake up in the morning. I feel a bit easily sleepy, especially at the daytime. And my wife also told me sometimes when I sleep, I tend to snore.
Right, and you tend to snore as well. Okay, I'll go through each one of those problems and see if we can find out more about them. Firstly, can I ask about the headache? Can you tell me where exactly the headache is?
Yeah, I mean the headache is only in my forehead, especially when I wake up in
Mhm.
the morning. It tends to go away by itself.
I see. How long have you had this headache for?
It only comes in the morning. Sometimes not every day. Sometimes once or twice per week.
I see. What kind of headache is it? More of a sharp headache, a stabbing pain, or is it a throbbing pain?
It's more like throbbing.
I see. Does the headache go anywhere besides your forehead?
No, it usually stay in the forehead.
I see. Have you had any other problems besides this that comes with the headache? For instance, any problems with your eyesight, any problems with any numbness on your face?
Numbness, sometimes yes. I also realize that if I use uh uh sometimes when I wake up in the morning when I drink a glass of water, I tend to feel my hand is a bit numb. But when I do my jobs, when I do exercise, this numbness actually goes away by itself.
Sure. All right. So you okay? I'll get to that as well. So with regards to the headache, is there anything that makes it better?
Mm, Not really. I mean, it is not very disturbing for me. It tends to just relieve by itself after the morning. So I would, if you want me to get the pain severity, probably I would give like 2 to 3 out of
Okay.
10.
Sure. Of course. Just like to ask about this lethargy. Do you wake up in the morning already feeling tired, or do you tend to get tired more towards the end of the day?
No, only in the morning.
Only in the morning when you wake up. Okay, sure. The other thing with regards to the numbness in your hands, can I ask how long you've had that for?
No, it's about 6 months already.
6 months. Is it in one hand or is it in both hands?
Both.
Both hands. Oh, I see. Do you sometimes
Mm.
a bit clumsy? You tend to drop things? Hello?
No, I don't feel clumsy. Yeah, I don't feel
Yes.
clumsiness.
Sure. Can you show me exactly where on your hands that you tend to feel numb?
Yeah, you can see that my numbness area is usually at here.
All right. Okay. Sure. Can I ask whether this numbness, do you find that sometimes you have to shake your hands a little bit to get rid of it?
Yeah. Like I say, if I do jobs, activities, if I use my hand movement more, then the numbness tends to get better.
I see. All right. Okay. Thank you. Now, I'd just like to ask about your eyes. Can I ask if you've noticed any blurring of your eyesight?
I don't know this blurring, but I realize that when I walk, sometimes I tend to bump into objects at the side. Can be left, can
I
be
see.
right, can be both.
I see. And you've noticed this for how long?
Oh, this thing has also been there for almost 6 months now.
Okay, about 6 months as well. Can I ask if you've noticed any other problems with eyesight, for instance, for reading, or for instance, watching the television or looking at other people?
No, no,
I see. Okay. Any redness or pain in your eyes?
no.
Okay, sure. So the other thing is, have you noticed also any problems with passing urine, or have you noticed yourself passing a lot more urine than usual?
Yeah, yeah. The doctor have been telling me all this because of my uncontrolled sugar lah. So I tend to pass a lot of urine. I tend to drink more water as well.
Okay, sure. And you've noticed this about the same time as coming out with the headache and all.
Yeah.
Okay. All right. A few more questions. Can I ask if you've noticed any changes in your appearance?
Yeah, doctor. I didn't bring my IC, but my face has been become long and big.
Mm-hmm. And how you have any idea how long this has been?
Roughly about 1 year, I think. I mean, I started to realize it only in the recent weeks when my wife told me that suddenly I feel a bit bigger and taller.
I see. Have you noticed that you can't really fit into shoes or your wedding ring, for instance?
Yeah, yeah. I have to, I don't wear wedding ring, but for shoes and gloves, I need to upsize again and again.
I see. All right, sure. If you don't mind, just like to go through a bit, a few questions just to screen through. Can I ask if you have any chest pain?
No.
Have you noticed yourself feeling a bit more short of breath when you do things?
Sometimes when I exert myself, when I walk for a while, that I will feel breathless.
I see. And is that usually walking the amount of exercise or activity that you usually do, or is it a bit less than what you usually do?
It has been lesser, like, I would say. My
Lesser.
effort is already, yeah, my effort is reduced.
I see. Have you noticed yourself having swelling in your legs?
Yes, intermittently I realize that it's swelling over both sides of my legs, but it comes and go.
I see. Problems coming and going. All right. Can I ask you mentioned passing a lot of urine. Have you noticed the urine getting more bubbly than usual?
Yeah, I realized there's bubbles in my urine as well.
I see. Have you noticed any blood in your urine?
No,
Okay. Any problems or pain when passing urine?
no,
Any tummy pain of any kind?
no.
Okay. Any change in your bowel habits?
Previously I do have some blood in my stool, but it has been, I mean, just 1 or 2 episodes in the past, which I think maybe it's because of hemorrhoid or things like that. It didn't really bother.
Sure. And how long has this been?
The last episode was about 3 months ago.
I see. And can I ask if you've noticed any change in your stool?
Change in my
Your stool.
No, it has been there. I mean, it's the same. I don't have any loose stool or any constipation.
I see. No loose stool or constipation. How has your appetite been?
My appetite is okay. I would say good.
Sure. Have you noticed changes in your weight?
I think I gained a bit of weight in the past 1 year. Previously, I was 87. Now I think I was reaching 90s.
I see. Okay. Just like to ask a few more questions. Can I ask previously, have you had any medical problems besides the aforementioned diabetes and high blood pressure?
Yeah, I mean, I have diabetes and my blood pressure is also high. I was other than this, the doctor told me also I have high cholesterol as well.
Okay, sure, no problem. Okay, can I ask also in your family, are there any diseases that run in the family?
My father have high blood pressure. My mother have diabetes. Other than that, no one else have any problem.
Okay, sure. Now, if you don't mind, I'd just like to have a look at you. Just like to examine this patient.
Sure.
I'd just like to assess for the patient's visual fields, please.
Yeah, want to check for patient visual field, right? When as check, you notice that the patient have bitemporal hemianopia.
Okay, sure. Just like the quick screen to look at the pupils and look for pupillary reflex.
The pupil looks like reactive for you. It's equal.
All right. Okay, just like to do a fundoscopy as well, if possible. Specifically, just like to look for signs of any papilloedema, dot blood hemorrhages, or any cotton wool spots or copper wiring. Sorry, silver wiring.
As you do the fundoscopy, you realize that there's a bit of papilloedema that's blurring your optic disc margin.
Okay, sure. Just like to check for extraocular movements as well.
No extraocular movement issues.
Sure. Just like to look for any macroglossia. Just as the patient opens his mouth, if possible.
Yeah, there is macroglossia.
Macroglossia is present. Okay. Now just look at the hands, particularly looking for any wasting of the muscles.
No wasting.
All right. Like to perform for Tinel sign, Phelan sign, carpal tunnel syndrome.
Yeah, examiner say you can skip the Phelan sign, but Tinel sign, as you do, there's numbness over the median nerve distribution.
All right, over the median nerve. All right. I'd just like to auscultate heart, basically to palpate for displaced apex beat and any murmurs.
Yeah, the apex beat is displaced at 7 intercostal space, anterior axillary line. Yeah, anterior axillary line is displaced, and there is a pansystolic murmur heard at the mitral
that broke
region.
off.
Yeah, there is a pansystolic murmur over the mitral region. Can you hear me?
All right, murmur over the mitral.
Yep.
Oh yeah, I can hear you now.
Apex
Sure.
beat displaced. Yeah,
Okay.
apex beat displaced.
Sure, apex beat is murmur at the mitral region. All right, sure. Now can I just look at the patient's legs, particularly just to look for any pedal edema? Right, also
No
the shoe
pedal
size.
edema.
No
Yeah,
pedal
shoe
edema
size
as
like
well. Okay. Yep.
Mm.
Okay, all right. So apart from that, just like to quickly examine the abdomen, feel for any organomegaly.
When you feel for organomegaly, there's no hepato or splenomegaly.
Okay, sure, no problem. And just like to, okay, okay, and also just, okay. All right, thank you very much. Now I'd just like to ask a few more questions here, Mr. Ahmad. Yeah. Can I ask if you are currently married?
Yeah, I stay with my wife, like I mentioned.
I see. May I ask if you have any children?
Yeah, I got 2 children.
All right, sure. And how old are they?
One of them is actually 12 years old, and another one is about 18 years old.
Of course. Sorry, but this may be a bit personal, but I'd like to ask, have you noticed any problems being intimate with your wife recently?
Yeah, I have a bit difficult for erection, especially and I have conveyed this issue to my doctor. The doctor says it's because of my uncontrolled sugar.
Sure, of course. We'll try and get to the bottom of this, and we'll try and get it sorted out as best as we can. May I ask if you smoke, Mr. Ahmad?
No, I don't smoke.
You don't smoke. Okay. Can I ask if you consume any alcohol?
No,
Have you taken any recreational drugs?
no.
Okay. And can I ask what you do for a living?
Yeah, I worked as an accountant previously. Now I already retired.
I see. Okay. Sure, no problem. Now, I've just had a look at you and just also just examine you as well.
2 minutes left.
Sure. Can I ask if you have anything in particular you're worried about, concerned about?
Yeah, doctor. What is the cause of my uncontrolled sugar?
All right. Well, Mr. Ahmad, I feel that based on what you've told me and what I've had, what I've seen with you, the cause of your high blood pressure and your uncontrolled sugar may be due to the same thing, which is a condition known as acromegaly. May I ask if you're familiar with this term?
No, what is this, doctor?
Okay. Now, acromegaly is basically a disease which is caused by a growth, the gland which is directly under your brain, known as the pituitary gland. This gland produces chemicals which actually can influence the growth of cells in your body, and also can affect things like your blood pressure, your sugar, as well as your the growth of your bone, which is also the reason why you've been having changes in your appearance. Are you with me so far?
Yeah.
Okay, sure. So,
Is this doctor?
okay, now there are a few tests that we need to take to confirm it. Mainly, we need to do a few blood tests, but mainly I also need to schedule you for a scan of your brain in order to confirm this diagnosis. Now, if we do notice that there is a growth in the gland just under your brain, there may be a possibility of going for surgery in order to remove this gland or to remove the growth over the gland.
Okay. And
Alright.
if I don't want surgery, can I just take medication?
Okay, there are options to go for medications. May I ask if you have any other concerns, particularly with surgery? Is that a reason why you're asking me?
No, it sounds very scary to me, doctor.
I see. I
just-
do appreciate it. Sure, I do appreciate your concern. Now, there are a few options as well. There are medications that you can take actually in order to sort of shrink or to control the gland, and there is also the possibility of doing radiotherapy, which is basically shooting high energy X-rays into your skull in order to
Okay,
sort of.
thank you, Dr. Benjamin. Thank you.
Thank you.
Time's up. Yeah,
Sure.
Dr. Benjamin, can you run through a list of differential diagnosis in this patient?
Okay, sure. Sure. In particular, this patient here presenting with hypertension as well as diabetes features also suggestive of acromegaly, in particular, possibly caused by pituitary adenoma. However, other differentials I like to offer for a cause of his hypertension may also include things like essential hypertension, possibly also with any renal involvement, diabetic nephropathy, and also I also like to investigate further for his cause of his cardiac issue, in particular suspicion of mitral regurgitation in this gentleman. Other causes that I would like to exclude may also include pheochromocytoma. So, although in this case,
The patient chief complaint is uncontrolled sugar, right?
uncontrolled sugar, that's right.
Yeah, and you realize the blood pressure is high. But what are the explanation of uncontrolled sugar other than possible acromegaly?
Other possibilities for uncontrolled sugar, I also particularly rule out other secondary conditions like hemochromatosis. And the other possibilities could also be any pituitary tumors such as glucagoninomas, although in this case seems a bit less likely, given he doesn't give a history of any skin changes.
Have you assessed the patient insulin?
No, I've not. I'm afraid I've not assessed for the patient's insulin as well. I did not particularly. I'd like to look also for any signs of lipodystrophy and also insulin injection technique.
Yep. Okay, good. Then tell me about complication that you have encountered and signs that are present in this patient in terms of acromegaly.
Okay, sure. Going from head to toe, I believe the patient now has a bitemporal hemianopia, probably consistent with optic chiasm compression. There's also the presence of carpal tunnel syndrome, which is commonly associated with acromegaly as well. Presence also of mitral regurgitation, which in this case may be due to dilated cardiomyopathy. There's also the presence of polyuria polydipsia, probably also due to possible causes may include a cranial diabetes insipidus, possibly renal salt wasting or cranial salt wasting, and also because of diabetic nephropathy as well. Other complications in this case may also include failure symptoms, which might also be secondary to the cardiac issue, and also hypogonadism possible, given the history of erectile dysfunction, although again, this could be caused by diabetes.
How about anything about early morning headache or snoring at night?
All right. This might be due to obstructive sleep apnea. I would have taken a better history about stop bank score as well.
Okay. How will you investigate this patient?
Okay, so the investigations, full blood count in particular, just to look for presence of any abnormalities, renal function, given the patient gives a history of any of a polydipsia, liver function test as well. But specific investigations, things like thyroid function tests, just to look for any hypothyroidism. Also look for and also I would take an AM. But for the definitive investigation, I would like to perform an MRI pituitary protocol, just to identify presence of any pituitary adenoma as well as any optic chiasmal compression. Other tests that I'd like to do for is an ECG, given the history of failure, echocardiogram, as given the presence of a MR murmur. I'd like to perform a test with AM cortisol as well, just to look for any hypocortisolism in this case, and also do a urine spot for urine sodium, urine osmolarity paired with serum osmol and renal function as well.
Okay, so before you do an MRI pituitary gland, what are the screening and confirmatory tests that you want to do first?
Okay, screening test, I like to do insulin growth factor 1 level, and if it's raised, I like to proceed to an oral glucose tolerance test for suppression of growth hormone, and a positive test would lend credence to the possibility of acromegaly.
What is the positive test for OGTT test?
OGTT test would be for growth hormone.
What would be the expected finding?
Expected finding here would be failure of suppression of growth hormone.
Okay, sure. Then, how will you manage this patient?
So management of the patient, we could split into pharmacological, surgical, non-surgical, and also for firstly, this patient will need to be managed as a multidisciplinary team involving the endocrinologist, neurosurgeon as well, diabetic educator, nutritional support, as well as physiotherapy for his carpal tunnel syndrome. In particular, I'll offer this patient for resection of his pituitary adenoma if it's confirmed. The ideal approach would be transsphenoidal. Other modalities may include things such as stereotactic radiosurgery or radiotherapy, and also medical management of the acromegaly as well.
Okay, time's up. Okay,
sure.
thank you.
Okay.
Okay, thanks. How do you feel? How do you find about this scenario?
I did not do very well, which I think is a bit disappointing considering that the answer was kind of there as soon as you showed the photo. I felt that I could have done a lot better and organized my thoughts a lot better. And definitely.
So the initial chief complaint for this patient is difficult to control sugar, right?
That's right.
Yeah, but I realized that your main goal of this discussion actually shifted to the headache and the uncontrolled hypertension in the initial history taking. You spent about 4 to 5 minutes on the headache and also explore a bit of OSA, and then subsequently come back to headache, and then the carpal tunnel part comes in, and then you start to screen for the other complication. So I think you actually spent a bit of time there, which I think you should be a bit more focused. So first, I think still need to go back to the HOPI. When a patient that comes to uncontrolled sugar, you need to ask a bit of the reason of uncontrolled sugar. So you need to really explore a bit. Has there any issue with the injection? Is the insulin is expired? Have you checked the dates? And then do you have any issue in the skin problem? You should ask about all those basic questions first. Because the chief complaint is still uncontrolled sugar. You need to address that one. I know that this is a very straightforward acromegaly, but you need to really go into the detail of what causes the uncontrolled sugar other than acromegaly first. Okay?
Right. Yeah.
And in terms of I can see that you try to screen complication of acromegaly, but I think it's consuming a lot of time in the history. That I mean, you should keep it short. And I realized that another thing is that, as opposed to the ComSkill, this is a station that you try not to give too much positive feedback to the patient. Like, yes, I see. Okay, all right, sure. You repeated almost every question almost every answer that the patient give you. So it's a bit consuming. So when the patient asks you, yes, the patient tell you the answer, you just proceed with the next question. It's okay. Right? On and off, you can give some positive feedback, but not every question. Right? Okay. So that will save a bit more time for you to really ask about the question. But generally, your knowledge is there. It's just that you have difficulty to squeeze in during the discussion. And during the investigation part, what I realized is that you talk about a lot of things, but you did not mention how to confirm the diagnosis of acromegaly to begin with, because this is a sure thing of acromegaly. But you mentioned about the MRI pituitary, which is a bit risky, because we know that it still go back to the hormonal test, the screening, the confirmation, only then the role of MRI, because MRI usually, even if it's negative, it doesn't exclude acromegaly, right? And at the same time, it's not we always need to go back to biochemical analysis, only then proceed with radiological. So you must mention that to confirm diagnosis of acromegaly, then you want to do the screening test followed by confirmatory and then MRI. And then only then you want to screen for complication, then you mention one by one. Because you mention things like basic things, food blood count, things like that, which is not very relevant. So that's why you lost the track that you want to screen for diabetes, want to do a HbA1c, want to check a fasting lipid sugar. And most importantly, in this patient, because of pituitary chiasmal compression, you want to screen for pituitary hormonal panel. It's a routine test that we do for all acromegaly patients before go for surgery, right? We want to optimize all the hormones and replace, anticipating the replacement to be done after the surgery and the planning things. So it's also important for you to mention, for the hormonal panel screening. And yes, echo, ECG, all those okay. And you can even mention nerve conduction study for the carpal tunnel, and you can even mention about sleep study for the OSA part. Okay, but generally, acromegaly is a difficult station if it come out in the consultation, because there's a lot of things to cover. But you need to have your approach, because I can see that you are everywhere and you try to remember everything, and sometimes it may really consume your time to recall back, and you miss the patient that OSA symptom when you finalize the diagnosis, right? The complication part. So again, to me, I like to make things simple. When I encounter acromegaly and I'm sure that this acromegaly, and want to do I want to but I don't rush to go into the diagnosis straight because usually they will have a bit of stent, uncontrolled hypertension, uncontrolled sugar, things like that. Or unless the stent is something related like increase in size of face or hand or even foods. So then that is easy. But sometimes if the stem is like uncontrolled sugar, you want to explore a bit on the uncontrolled sugar part first before you go confirm the diagnosis. But generally, after you exclude all that, then to confirm the diagnosis, only three important questions, right? Eventually, you want to change in the face compared to the previous photo, and then the hand size, and then the shoe size, ring size, and then skin changes. After this is positive, then you go screen one by one the complication. Yes, diabetic, you ask a bit more already. Then the high blood pressure, the carpal tunnel. I like to go like vital sign first, then go to periphery. Then don't remember about, you can remember head to toe as well. Can't start from the eye or then periphery. There's no right or wrong, depending on what is the flow. So if I go from periphery, I will screen for carpal tunnel. Then I go to the eye straight because I don't want to forget about asking about bitemporal hemianopia later on. At the same time, I want to rule out any cataract or atrophy. And then go to the neck. Neck is only thyroid and OSA. Then I go to the heart, basically cardiomyopathy. Then don't forget about this pseudo gout, which is, and the OA is quite common. So must ask the patient whether there's any joint pain over the hips and the knee, especially. Okay. And yes, you have mentioned about the hypogonadism part, but don't forget that the patient also got blood in the stool in the past, right? For this kind of patient, I will offer to do a per rectal examination after I finish my examination because the history actually got some blood in the stool intermittently, although there's no alter bowel habit. Because you know that the association, this is complication that we need to screen through. Okay. So next, I usually jump to the complication first. Only I localize the etiology. Yeah, I mean, you're sure that this patient bumping thing at the side got double vision. Yeah, then you know that it's pituitary. But as soon as you need to exclude the ectopic part, in which you did ask, I thought you almost forgot to ask about smoking part. Luckily, you did to ask the social part. So whether there's any coughing of blood, do you smoke previously? Because lung cancer can also cause acromegaly secondary due to ectopic hormone secretion. And getting a diagnosis of acromegaly alone is not enough. We always need to screen for MEN1. Okay, association is something very important. Therefore, it's important that when I ask for GI, and also other than screening for the cancer for GI, colonal cancer, I'm also screening for any pancreatic tumor, which is the loose stool. Sometimes they will have oily, frustrating stool, like malabsorption kind of stool that not improved by fasting. And yes, parathyroid hyperplasia, mainly the hypercalcemia symptom, patient can have excessive drinking of water, polyphagia, usually can have tummy pain and also stone in the kidney. So that's why you need to ask in detail. You ask about tummy pain, yes. You also ask about any pain when you urinate, when you pass urine, or any pass out of stone in particular. And the next thing is the syndrome association, which is you just need to ask any skin dark spot over your skin to really screen for this, the Albright, McLean Albright or Carney, which is quite rare. But anyway, if you run through all this, then you know that you covered acromegaly, everything already under the sun. Okay, so it's quite safe. So only then you spend some time to examine the patient as well as asking some social history and then the concern part. But I realized that when you explain to the patient, what am I having, doctor? You should have mentioned that I think you have a condition called acromegaly. It's not wrong to do that. And your next sentence is followed by, do you have any idea? Do you heard about this before? So sometimes you mention this at the first, then examiner may consider you as using a jargon. The safer way is actually to do is you mentioned that it may be due to abnormal hormone production because of some growth situated in the middle of the brain, and this condition is what we call as acromegaly. Probably you don't want to review the name of this acromegaly at first. I mean, there's no right or wrong. Some examiner are okay with it. Some examiner are quite particular. So to be safe, I will always try to explain the simple words first, and then only I tell them this condition is called acromegaly. But please don't be bothered by the term. It's a condition whereby there is some abnormal growth that cause abnormal hormone production in the middle of the brain, something like that. So examination is also very template. This is a station that you really need to score. And if you go to this checklist, let's see how many things that you miss a bit. So you examine the hand. You have to comment whether the hand got any split line, doji hand, and then comment on the sweaty palm because it suggests of the active disease, right? and then you need to look for any sweaty palms. Okay, so you offer for the Fallon is just the offer, but you can do tinea sign when you examine the palm. And then you go to the head. Okay, you also want to describe the acromegalic facies, and then basically eye visual field. Don't forget, which is good. You straight away ask for visual field. That's the first thing you want to examine because you will forget sometimes. And then fundoscopy, yes. And then go to the neck. Don't forget to check for goiter, and also ask for neck circumference, check for any skin tag and acanthosis nigricans. So it can be in the axilla, it can be in the neck. Then you check for proximal myopathy, which can be happening in acromegaly or any endocrine disease like Cushing, like thyroid disease. And then go to the chest, check for any axillary hair loss to suggest hypogonadism or even gynecomastia. And also check for any skin tag and acanthosis nigricans. Then go to heart, listen for the apex beat and also the murmur. And then if you've got time, all these things I feel is not very important, abdomen and knee. But I think that with the new format coming out, we are expected to do because there's more time. So yes, you should proceed to check for any hepatosplenomegaly to suggest secondary amyloidosis because of acromegaly. And then knee as well to look for any, you should feel for the knee joint to look for any joint tenderness to suggest pseudogout. And then check for pedioedema in which you did, which should suggest the active disease. And then the per-rectal examination to exclude the bleeding, just offer. And then I think you should also request to repeat the blood pressure because you notice the blood pressure outside is a bit high. And also want to check for the bedside urine dip and also the bedside sugar. I mean, all these things is something that can help you because if got glucosuria, if the blood pressure still high, sugar still high, I mean, for the history, it looks like high. But for examination-wise, got pedioedema, got skin tag, got sweaty palm, all this already suggests active disease. You want to mention the full diagnosis of, I think the patient having uncontrolled diabetes secondary to acromegaly in the active, which have the active disease in the active stage of disease. You can mention something like that, complicated by blah 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 blah, all the positive signs you mentioned. Okay, and the thing investigation for this kind of endocrine station, like I mentioned, I like to confirm the diagnosis first. Unless I'm not very sure with the diagnosis, I want to offer differential first to exclude. Only then, as I mentioned about confirmatory with screening and confirm. So usually for this, like straightforward, I mentioned that I want to confirm my diagnosis acromegaly by doing screening. IGF-1 will expect to be high. Confirmatory OGTT will expect unsuppressed. And then localized with MRI pituitary, can even do a PET-CT if the lesion is not typical or suspecting there's some other lesion, hypermetabolic lesion elsewhere. And then to screen for association and complication, I will do this. Yeah, that's all. You can see that why I mentioned pituitary hormone is also important. Complication, sometimes the compression of the chiasma can also cause reduced production of hormone in different lines. Okay, lineage. And the colonoscopy is also important to be mentioned if patient have a GI bleeding. Okay, and management is also important to mention the non-pharmaco if you got time, cardiovascular risk reduction, exercise weight reduction, and then medical and surgical. You should mention if you want to mention in faster way, you should mention that can be surgical, can be stereotactic RT, or can be medical. Medical can be few things, can be dopamine agonist, somatostatin analog, and also GHRH antagonist. Prednisone is something they tend to ask more frequently nowadays because with the newer therapy. But I think it's also important for us to know about the bromocriptine, the dopamine pathway, the somatostatin pathway, and then only followed by the GHRH antagonist. And then the surgery, you should mention the transprenadal surgery because you know that macro adenoma cannot just medical therapy, must be surgical. And then colonoscopy as well for surveillance. So if you manage to mention everything under the sun, like what I mentioned here for acromegaly, I think you will get a full mark, definitely. But this kind of scenario, their expectations are high. They are expecting us to do a lot of things, to ask a lot of things, and examine a lot. So that's why it's also good for us to revise back again what is acromegaly and then to go through again. Generally, I think you do well. It's just that maybe you miss out the point here and there. But I think generally, a lot of examiner can still give you almost full marks. Don't worry. Just that you need to be more fluent. At the same time, avoid those positive feedback terms that because you realize that sometimes you mention too much, you become a bit a bit too sometimes can be annoying for the examiner. Say okay, yes, okay, sure, but probably it's okay not try not to give the feedback for every single answer lah. Okay, and then you have to. Yeah, it's a habit. I mean, we all do that. So sometimes you may also want to change your your 台词, your choice of words. What are the options that
good.
you have? Yeah, just like, I see, right? Okay, sure. Know what else? I can. Okay, so okay, I've understand. Okay, do you have anything else? No, you want to change your a bit of your words, choose the wordings. But I think you'll do well. Don't worry. Huh? Just that you need to be more exam orientated and more concise only. That is my comment. Okay. Do you have any question?
Just a couple of questions. The first thing is like what you mentioned, doctor. There are a lot of things to screen through for acromegaly. So would it be fair if, let's say, I elicited that symptom in one sentence, like, okay, you've got numbness in your hand, and getting worse, like particularly at night, that sort of thing. If I've elicited like that point, can I just move, or because I feel like I've
Yeah,
lost
you
a
should
lot of
move on. You should move on.
expanding. Yeah, I've expanded on each symptom too much, and I think that's way too time consuming. And
Correct,
like what you
correct.
miss a lot of things because of that.
Yeah, so
The-
usually the screening part, I mean, you're asking complication one by one, right? So if you write outside the scenario, when you write, I mean, definitely this kind of scenario you don't know is acromegaly lah, oh. But if you prepare enough, the moment you encounter acromegaly, you will shift the focus to this. This is in your mind, so you just go by checklist. Okay, I want to ask one sentence or one or two sentences for each one is enough. Is more than enough. You don't have to explore a bit more in detail. I mean, the headache is not the big focus here, but you can explore about the headache because it can be related to uncontrolled hypertension, causing hypertensive emergency, things like that. You are concerned, you can ask. But the rest of it, you can just ask very quickly. Do you have any breathlessness? Do you have are you able to lie with just one pillow? Do you suddenly wake up at night because of shortness of breath? Do you have any leg swelling? After you complete this four sentence, okay, cardiomyopathy exclude. Then you proceed to the next. Then you will save a lot of time.
all right.
Okay.
One other thing, in this case, if let's say the patient doesn't give a suspicion of, say, the problems with loose stools or any problems, particularly with hypercalcemia, at what point then do I put in sort of like the screening for the other manifestations of MEN1 syndrome? Like, do I do a system EB or do I do like a CT pancreatic protocol only if I suspect if the symptoms are out, or do I just go as with the usual acromegaly script otherwise?
You mean under the investigation?
Yeah.
So usually we don't. I mean, under investigation we usually don't don't routinely mention lah. But that's why in my notes here you mention the PET-CT, right? PET-CT is something can be helpful because if it lags out in the pancreatic, then yes, it can be MEN1 lah. But MEN1 syndrome again is not about the investigation, but it's about the history. If the history is not suggestive of MEN1, then usually there's no role to screen lah. But to be on the safe side, that's why I also always mention something that to be on the safe, I will also localize. I mean the PET-CT lah. But generally, we should, if let's say positive history, then we need to think about MEM1 and we need to screen for that lah. So we can do the what we call as fasting gastrin and fasting. There's some more tests that we can do lah, including the specific one will be a dotatate functional scan. It's a PET scan, dotatate scan.
All right. Thank you very much.
Okay, thanks. Anyone got any other question? If not, we'll proceed with the last station with Dr. Alden again. Think okay, right? So it's always good to revise acromegaly. Although I think that nowadays maybe the scenario will still come out as acromegaly, but maybe the stem may not be like straightforward. So for the Benjamin station, I would expect him to really check for any insulin injection site, especially the paraumbilical area, any lipodystrophy to suggest the suboptimal insulin use. So it's also important because go back to the stem again, it's an uncontrolled sugar, don't know why. So yes, we always need to know that this can be due to more sinister cause like acromegaly, but we have to exclude the common thing first, which is try to assess a bit on the insulin technique. I know we are not expected to do that in real exam, but just ask a bit any difficulty, any issue, skin reaction or anything, any missed doses. Okay, so that will be very helpful. Okay, Alden, are you ready for the last one?
Okay, can.
Okay, so I will give you I will give you 5 minutes and your time start now. Okay, Dr. Alden, time's up. This is the surrogate, Miss Anna. Please start.
Okay, hi, Miss Anna. I'm Dr. Alden here, one of the doctors in the neuro clinic today. Can I confirm that you are Miss Anna, 30 years old?
Yeah, I'm Anna.
Okay, so we are here today to talk about your dad's condition, Mr. Charles' condition. Is that okay?
Yeah, sure.
Okay, so can you tell me more about your dad's condition?
Yeah, doctor, I'm very concerned because my father has been having a memory issue for the past 1 year, and we feel that his condition is actually uh, deteriorating.
Okay, all right. So I'm so sorry that you are going through this along with your father. So hopefully we can help you with something, all right?
Okay.
All right. So can I know that how long has this problem your father has been going on?
Yeah, so for the past 1 year, we noticed that he become more and more forgetful lah. Previously, he's really can recognize us, and then can really recall what he usually eats or what he usually do. Like he is very active lifestyle person. But for the past 1 year, gradually we realized that he tends to misplace objects and he tends to be forgetful, especially he forgot that he already eaten the breakfast, he had to eat again. He forgotten that he already washed the clothes and he tends to wash again. And then at the same time, sometimes we realize that he does not recognize us. He cannot call us by the name.
Oh, okay, all right. Um, does this happen? Is this condition fluctuating? Meaning sometimes he's okay, sometimes he's not okay. How does it go?
Yeah, it's a bit fluctuating. Sometimes it looks okay for us. I mean, be able to call my name and then can do things. But sometimes it's like really cannot do anything. Just blank stare and then sometimes just forgetful.
Okay. So regarding this memory loss, does he lost the memory that he's forgetful? Is it something quite recent or is something usually way back? He also had this problem of remembering.
Yeah, I mean this thing has been there for progressively. Like I would say, it is not because he initially he can remember all those olden days story, no problem. But recently we realized for the past few months he cannot recall what he eat for breakfast, and then at the same time, sometimes when I mean things that happened recently, like 1 week ago, he also cannot remember. So we are a bit worried.
Okay, sure. Uh, do you remember that does he have any trauma or any falls before this happened?
No,
Okay. Um, does he complain to you of any headaches or any during this 1 year period?
no.
Do you remember him falling down more frequent recently?
Not really.
Okay. Does he complain of giddiness to you?
No.
Okay. Um, so when at home, who is the one taking care of him?
Yeah, I'm the main caretaker for him.
Okay, all right. You're living with him.
Mm.
Okay. Do you notice, is there any problems with his walking? Is there any clumsiness or is walking
Yeah,
different? Yeah.
I realized that he become a bit difficult to walk. He tends to walk in a small step like that.
Okay. Okay. All right. And you notice when he walks, does he has reduced swinging of his arms as well?
Oh, this one I'm not very sure, not very aware of.
Okay. All right. Sure. Do you notice that when he does things now recently, is it very slow?
Yeah, he's a bit slow lah to do everything. Generally, it's a slow.
Okay. Does he, when he talks to you, does his voice become softer even as well?
I would say almost the same.
Okay. So around this 1 year period, does he complain of any weakness over the one side of the body?
No,
And does he complain of any funny sensations of his hands, feet?
no,
Okay. All right. Throughout this 1 year, do you notice that he's having problems with incontinence, meaning that he passes out urine that he cannot control?
no.
Okay. Have you ever noticed that he has been having these abnormal movements of the hands or the feet or the head?
Feet, yes. But head no.
Okay. What about his hands?
Yeah, hand also sometimes, and resting, we tend to realize that he shivers.
Okay. Okay. So, what about when he's doing something? For example, taking a cup or buttoning his shirt. Does the shakiness still there?
We tend to realize lesser if he do that. He do
Okay.
something.
Okay. Then throughout this 1 year period, have you noticed that he's been talking to himself, like there is no one there? Is he having any hallucinations?
Hallucination. Now that you mention it, sometimes I realize that he tends to say that he sees some people that already passed away actually, and he see the certain person in our house, and then sometimes talking to him also.
Oh, I see. Okay. Is he being aggressive to you all at home?
Not really.
Okay, sure. Let me just ask a few more questions so that I don't miss my diagnosis. Does he have any change in his bowel habits recently?
No,
Okay. Any difficulty in swallowing or eating?
no,
Any change in his weight?
no. I mean, I realized that he tends to eat lesser nowadays. Like I suppose he lost some weight, but we never really weighed him recently.
Okay. What about any coughing throughout this period?
No,
Any difficulty in breathing?
no,
Any chest discomfort?
no.
Okay. Does he complain that he has also has some pains in the hands or the feet?
Not really. He didn't complain.
Okay. Any rashes that you notice this past 1 year?
No.
Okay. So may I know your dad does he have any medical condition previously?
Yeah. My father have diabetes and hypertension. He's taking metformin 1 gram BD and also amlodipine once daily 5 mg.
Okay. How is his diabetic control? Do you know?
Last we checked in our GP 3 months ago, the doctor say the sugar is good lah. The 3 month control is about 5%.
Oh, that's good. That's good. How about the blood pressure?
Oh, his blood pressure we usually check at home because we worry he sometimes he walk in a small step, we worry he will fall. So his blood pressure usually stays about 120s to 130 in the front, and the back is about 60 to 80.
Okay, that's very good. Where does he follow up for his diabetes and high blood pressure?
Yeah, he's followed under our family GP.
Okay, sure. Anyone in the family that you know of having memory problems as well?
No,
Okay. Anyone in the family is having cancers?
no,
Okay. Is he taking, apart from the metformin and the amlodipine, has he been taking any traditional medications from outside or supplements?
no.
Okay. All right. Previously, what is your dad working as?
My father working as I mean previously is he retired 8 years ago. Like previously he's a government pensioner. He worked as the custom officer.
Oh, okay. Is he a smoker or was he a smoker?
He is not a smoker.
Previously, he didn't smoke as well.
No.
Okay. Is he taking any alcohol previously? Or
Yeah, speaking
mm,
about alcohol, he is a heavy alcohol drinker when he was young. And then nowadays he still drinks about, I would say, 2 to 3 cans per day sometimes.
why he's still drinking as well?
Yeah, he still he likes to drink alcohol. We cannot stop him.
Oh, okay, all right. Does he have you guys talked to him about cutting down?
Yeah. I mean, we always advise him to cut down, but he say he already old. He really enjoy drinking, so that's why we tend to just give 1 to 2 cans per day instead of like 3 to 4 cans in the past.
Okay. Um, is he traveling recently, this 1 year or previously in the past?
No.
Okay. So can I just check on your dad, Miss Anna?
Okay, sure.
Okay. So just general appearance of him, is he cachextic looking?
He is a bit caucasic, a bit deconditioned. There's
Okay.
a lot of wasting temporal over the temporal as well as the muscle over the proximal,
Okay.
upper limb and lower limb.
I want to assess his gait. Is there any shuffling gait or reduced arm swing gait?
Okay, so when you ask the patient to walk, the patient stand up slowly in the stoop posture, and then the patient start to walk. As the patient walk, you notice there's a short suffering gait with the but not really any reduced arm swing. The arm swing looks like preserved both sides.
Okay. Just want to assess any upper limbs. Is there any rigidity, cord rigidity or any lat pipe rigidity?
There's a bit of cogwheel rigidity, but no lat pipe. Both sides.
Both sides. Okay. Does he any resting tremors?
There is a tremor over the both sides as well. Both upper limb and both left and right hand.
Resting tremor, right?
Yep.
Okay. Just want to confirm with intention tremor, does it disappear?
So when you do a intentional tremor, there is no intentional tremor.
Okay. So I want to assess his mental state. Do an MMSE examination.
The examiner say you can skip.
Okay. Is there any, just check for cerebral signs as well, is there any nystagmus?
No nystagmus.
Is there any pulse pointing or dysdiadokinesia?
No pulse pointing, no dysdiadochokinesia.
Okay. Then just look again once more. Is there, apart from the tremors, is there any abnormal choreotic movements?
There's no abnormal movement.
Okay.
The examiner want to ask you at this point of time. Examiner say that MMSE is not practical for exam short case purpose. Do you want to offer anything else?
You just want to ask basic, not the full MMSE, just ask his orientation, his
what kind of question you want to ask the patient?
Who is the one brought him here? Who is the doctor? Does he remember the doctor? Can he recognize the doctor?
So Mr. Charles said that yeah, she is my daughter, but I cannot remember her name.
Okay. Does he recognize the place he's in now?
Yeah, he don't know where is he now.
Does he recognize the date and time now? Or the year?
Cannot recall.
Okay. Just want to ask him to name some 3 objects. Simple objects.
So so what object you want to give him?
A pen and a fan and a chair.
Okay. He remember pen. The cannot remember the remaining 2.
Okay. Just ask him to count. Speak word behind, backwards.
Go behind backwards. You mean the spell, the letter?
Oh, yes, correct.
He have difficulty to do that.
Okay. Just want to ask, can he subtract by 700 by 7?
Oh, examiner say you can skip that.
Okay, all right. So just want to ask, so Miss Anna, can I know what is your concern?
Yeah, doctor. Is this Parkinson?
Okay. So Miss Anna, yes. We are thinking of what your father is having now. He's something. We think he has something called Lewy body dementia.
Oh,
Just
what's
don't mind
that,
the
doctor?
term. Okay. So this term Lewy body dementia.
2 minutes left.
Okay, it happens when he's showing signs of thinking memory loss, which also associated with signs of Parkinsonism. Like for example, your dad has memory loss. At the same time, he has been showing signs of slow movements, with small steps when he's walking, and some shakiness of his hands. All right. So, okay. So I'd like to just your father, do some further tests on him. I would like to do some regular tests, and also to check on some vitamin levels. And also I'd like to do some scans of the brain just to make sure we are not missing any strokes or any something that is wrong with inside the brain. And also at the same time, I would like to start your father on some vitamins, as he is on long-term alcohol. He's drinking it for some long term, and this also would affect his memory as well. So at the same time, I would like to ask you we will talk to him about stopping alcohol, and at the same time start some medications to help with this problem with the memory. Is that okay?
Okay. Will this condition progress and become worse?
Unfortunately, yes, Miss Anna. So, however, there are treatments available to slow down the progression of this condition. So we'll once this condition the test is back and the test we have done is confirmed to show that he has Lewy body dementia, we will start him on some medications to help with to slow the decline of this his memory loss.
Oh, okay. And you have mentioned that he needs a brain scan, right?
Yes.
Okay. Can this condition be due to alcohol alone instead of this Lewy body dementia?
there is a possibility that this can be caused by alcohol induced. However, this also is part of my what I'm thinking about his condition. So I would
Okay.
like to.
Right.
Okay.
Thank you, Dr. Eldon.
Mm.
Okay, would you mind to go through the list of differential diagnosis and mention the most likely diagnosis in this patient?
So my most likely diagnosis for Mr. Charles would be a Lewy body dementia, as he has shown exhibits signs of progressive decline of memory impairment associated with signs of Parkinsonism. However, this Parkinsonism signs is not typical as it is happen in both both upper limbs. He also has signs of hallucinations as well, which is also quite a typical in Lewy body dementia. So my other differentials that I would like to consider would be a vascular dementia, as he has chronic diabetes and hypertension, which might lead to some vascular impairment in the brain. Also, another differential would be alcohol-induced neurodegenerative condition, which leads to his memory impairment.
What are the alcohol disease that you know of causing dementia?
Can cause cerebellar degeneration.
But there's no cerebellar sign, right, in this patient? What would
Yes.
be the diagnosis that is possible?
So I forgot to ask, is there when was his last drinking? So if let's say he has some withdrawal, would be alcohol. What is the Wernicke's encephalopathy? So could be if there's a worse, could be a Korsakoff psychosis, which he's now having some hallucinations.
Okay, good. So okay, all right. How about the any other differential diagnosis?
So lastly will be Alzheimer's disease. Yes, but Alzheimer's disease will be a diagnosis of exclusion after we excluded most of the reversible causes.
Let's say a patient have a bit of incontinence, as you mentioned, and with this kind of gait, is there any differential diagnosis that is possible?
I'd like to consider about normal pressure hydrocephalus.
Okay, good. So how we investigate this patient?
So I'd like to do a regular blood test, looking full blood count, looking for any signs of infection, raised white cell count, or any anemia. In particular, as he has chronic alcoholism, I'd like to expect macrocytic anemia. Renal profile, look for any electrolyte disturbances, or liver function test to look for any liver impairment as he is chronic alcoholic. And also, I'd like to do a vitamin levels, B12 and folate levels. I'd like to check for his hepatitis B, C, and HIV level status as well. So I'd like to do also a thyroid function test just to rule out any concomitant thyroid disorders, which can lead to memory loss. So I'd like to do a brain scan, CT scan of the brain, plain CT scan just to rule out any structural lesions in the brain. And to do a complete mental state examination to see the severity of the memory impairment. And I also like to,
Yeah, you were mentioning?
I also offer MRI scan also to look for any degeneration in the basal ganglia or the substantial nigra areas.
Okay, sure. So how will you investigate this patient? Sorry, how will you manage this patient?
So I'd like to approach this with a multidisciplinary team approach, namely to refer to OT and physio for his gait impairment, and I'd like to refer probably a counselor to talk about his alcohol, and also to refer to a neurologist for this memory loss, and also to a geriatrician as well. So in terms of this Lewy body dementia, I would like to start him on some maybe cognitive enhancers such as memantine or domperidone. Memantine and donepezil. And also to refer to a psychiatrist for co-management, as he has having quite bad hallucinations as well.
Okay. How about what are the medication, what are the therapy that you can offer in terms of the psycho hallucination part?
So I don't think we'll need to. I don't think that antipsychotics will be a suitable choice for now, as I think it will exacerbate his the condition. I'm not too sure about this. And also start some maybe timing for his alcohol. Probably alcohol withdrawal. Just start some high dose timing for him. And to observe for any fits. If he has developed any delirium tremors, then we'll start on high dose of Valium, diazepam.
Okay, so let's say the patient have this psycho behavior issue, BPSD kind of issue. So what kind of antipsychotic is safe to give in this patient?
I will consider atypical antipsychotics such as olanzapine or risperidone. However, I'm not very sure.
Okay, all right, thank you. So time's up. Risperidone and olanzapine is
Not very sure.
totally contraindicated in this kind of patient.
Not very sure.
Yeah, and they are not atypical, right? They are typical.
What's the typical?
They are typical, right? The risperidone and olanzapine that you mentioned. I mean, you already got the answer correct. I mentioned because you mentioned atypical. I was like, okay, good, atypical. Then suddenly you mentioned the two example, which is the typical.
Is it? I thought typical is like haloperidol. Then this.
Yeah, typical. I mean, the
Q-type
first line is. I mean, the first generation is haloperidol, but then those olanzapine, risperidone, they are considered as so-called atypical, but they are also like very classic atypical lah. But the one that really safe for dementia or for elderly lah, in short for elderly lah, not only for dementia patient, is actually the quetiapine and the clozapine.
Okay.
These two are the safe. In fact, these two also can be given in Parkinson patient. It's the safest. I think there's another one which I cannot remember. But Seroquel is the quetiapine and the clozapine. These two will not cause the so-called the diuretic Mariner syndrome. At the same time, they will not cause too much of rigidity, because we know that Parkinson disease patient, they have hypodopaminergic effect, right? I mean, they don't have enough dopamine. But you are giving this antipsychotic is actually the anti-dopamine effect, right? Because we tend to use antipsychotic in those with high dopamine patient like schizophrenia or those very psychotic patient, right? They have high dopamine. So we are using this antipsychotic to deplete the dopamine store. So imagine you give haloperidol to Parkinson patient. I have experienced before. My friend give haloperidol to one of the Parkinson patient back in HKL. Oh, that patient really, we all almost intubate the patient. The whole day, the patient is totally GCS E1, V1, M1.
Oh, okay.
It can be very severe because you are depleting dopamine in a patient with a low dopamine storage to begin with. So those are very dangerous to be given, including risperidone and olanzapine. But actually, if you look at those BPSD management, it's okay to give risperidone or olanzapine with a very, very low dose. Very, very low dose. Haloperidol is also not to say fully contraindicated in dementia patient. It's just that the dose is really, really small. You're talking about like 2.5, 1.25 versus like 5 to 10 mg like that. And then it's not to say that risperidone and olanzapine cannot be given, but for Lewy body dementia and for Parkinson, these two conditions can get worse because they are classically they are already depleted in terms of the dopamine. So we try to avoid that. But those newer form of antipsychotic, the atypical newer form that does not interfere the dopamine pathway, which is the quetiapine, the clozapine, they don't interfere the dopamine pathway. That's why they are safe. Yeah. So anyway, how do you think for this scenario? Any comment, any issues?
I think it's a bit atypical for me.
Sorry.
I-
Yeah, I think your line is a bit choppy. Do you hear it? Yeah.
I can hear you.
Yeah. What are you saying just now?
I'm just saying that I think this is quite atypical for me. I think I need more practice for this kind of situation.
But I think you do well, you do really well. I would say that it's good. I mean, your approach, your history, your examination, your management is good. It's just that probably a bit of fine tuning. So for every patient that you think the patient has dementia, right? The criteria to diagnose dementia based on the DSM-5 is to exclude delirium and depression. So I can see that you try to exclude delirium by asking whether there's any, is it a episodic thing or is a persistent thing? But you didn't explore anything about depression. So another thing that you need to explore is to make sure the patient is not depressed. So you must make sure how is his mode. Do you think that he feels sad at home? So you need to explore a bit of the emotion to make sure that the patient is not depressed before you come to the conclusion that this is a dementia. And what is the patient age?
58.
Do you think it's a bit early for dementia?
Yes.
So we usually use a cutoff point of 60 years old. So anyone have this cognitive impairment less than 60 years old, which is progressive, usually we label that as young dementia. Okay, after excluded delirium and also the depression. So it's a young dementia. So young dementia, not much of differential diagnosis. It goes back to the differential diagnosis of young dementia lah. Okay, so but anyway, another thing is that during the history taking, I understand that you have explored about the memory, you have explored a bit on the immediate, recent, and remote. So you must also, I think you also explore a bit on the speech, any slurring of speech, any issue, but you also need to explore a bit in terms of the orientation and attention. So you must ask, in particularly, did he able to tell back what you asked him? Do you have any issue to understand? The comprehension part is also important. We know that cognition is not just about memory, right? It's about memory, attention, orientation, language, as well as comprehension. So we need to explore this five domain. In a way, it's a five domain under the history, something that we can ask. So you can say that, can he tell us where he is usually? So that if you do that, actually, if you miss it when you assess in the examination, it's okay because you have explored the attention. But because you didn't ask that, that's why in the examination you are not expected to do like MOCA or even MMSE. But I think it's important for you to at least know that whether patient is oriented to time, place, and person. This is, I think, is a bit more important. I encountered something similar during my practice with my consultant. So that scenario was also progressive memory decline, and I can't really remember the stem, but something like that. Then I also come to the conclusion that this patient has a Lewy body dementia. Okay, so but funny speaking, because the patient have the SpO2 is a bit low outside, it's like 95 or 94, something like that. I'm very concerned. That's why I examine for the lung. That scenario everyone do differently, It's like very funny. Some people check the lung examination like me because I'm sustaining pneumonia, constant delirium on top of dementia. Some people, they thought of this is because of constipation, want to offer PR. And some people want to do a memory test during the examination, which is also not practical. But only one candidate that do very properly, ask patient to walk, which is good. Because remember that every dementia patient or so-called cognitive impairment, we should ask to assess the gait. Because gait is the one that tells us whether got any Parkinson disease or any cerebellar syndrome, right? So we should ask patient to walk. So what you do just now is really correct. Another thing to do is to really assess the cognition. You should ask the patient, sir, can you tell me where you are now? Do you know what is the date and time? And then can you tell me what's the name and who is the one beside you? Just like that, very simple. No need to do, calculate. And the next thing perhaps you want to do is, if you got time, is to assess the speech, any slurring of speech. In the sense that can you repeat after me, like British Constitution? Or the next thing can you do is, can you count from December to January for me? That if you do that also, you can also in a way assess the speech as well. Okay, so I think if you do all that, is good enough. And if you want to do a neuro examination, maybe you just want to do exclude cerebellar and Parkinson sign only lah. Yeah, and differential analysis for this patient, definitely heavy alcohol is a red ring, is a red hanger. So basically, you want to rule out the possibility of Wernicke-Korsakoff syndrome. So if you go back at the calibration that I do, you got almost all is there lah. But the only thing that I feel is important is you want to make sure it's not delirium. Therefore, it's also important for you to exclude infection. You have excluded a few. I can see that you exclude constipation, you have exclude fever, but you didn't ask about any, photophobia kind of thing, or even any pain or stiff over the neck. It's okay. But I think for elderly, it's important for us to exclude UTI lah. No, UTI is something very common, and it's very common to happen in elderly. So that's why you asked about bowel habit, but I didn't recall you asked me about any change in urine habit, any foul smelling urine, or any pain when passing urine. All these are quite important to rule out UTI lah. And constipation is also important. Electrolyte is also important, especially if I got GI loss. And for this patient, I think I forgot to edit the examination. So this one is just the last 10 months for the young hypertension. But the calibration for examination for this scenario is to assess the gait and the cognition to exclude cerebellar and Parkinson syndrome. That would be the main goal. And then the differential diagnosis, yes, is Lewy body dementia because of hallucination and atypical Parkinsonism. So you have mentioned atypical Parkinsonism. What are the signs or points to suggest atypical Parkinsonism?
Symmetrical tremors, symmetrical rigidities, then absence of this, what is that? Absence of arm swing. There's presence of arm swing.
Arm swing is not very classic, right? I mean, for typical or atypical, because sometimes early Parkinsonism may not have reduced arm swing as well. But you mentioned the symmetrical onset. This is, yes, not suggestive. Another thing is,
Doesn't respond well to your medication, dopamine or that.
okay, good. That one is the later on after you start the medication, right? Then other than that,
I think presence of Parkinson plus syndromes.
yeah, which is the what are the feature? Early, everything is early, right? Early fall, early gaze palsy, early or even any cerebellar sign involvement.
Postural hypotensions.
Yeah, early postural so-called postural hypotension or autonomic instability. So all these are early. So you must mention that this is an atypical Parkinsonism, which I agree. And another thing to consider is always SCA and Huntington. Because Huntington can come out in exam. It's a UK favorite thing. So under the mode, it's also important to know that whether patient have any, any self-harm behavior other than the, whether patient have any sad, do you feel sad, any issue with the mode. You also try to assess whether patient have any self-harm behavior. And other than family history of cancer, right, you ask, also important for us to know whether any family history of mental disorder in the family or mental illness or any history of self-harm in the family. Because when they grow out Huntington, no? Another thing is the SCA, spinal cerebral ataxia. Usually they become wheelchair bound early. And encephalitis, yes, something that we need to exclude, but usually it's just infective symptom, no? And then you mentioned about infective screening. I will expect you to mention, since you mentioned infective screening, I expect you to mention about syphilis, but you didn't. But anyway, it's okay. It's not part of a routine workout. Some they treat it as a routine, but even if you didn't mention, it's okay. To me, the most important thing is to mention the reversible causes of dementia, which is a hypothyroid or hypothyroid, the vitamin B12 deficiency. These two are the most important thing. And you want to mention VDRL because it's treatable, it's still okay. And then the CTs, MRI, yes. And then you should go by domain and domain. Like let's say this patient condition, yes, you can start the cognitive enhancer for this patient. Can consider choline esterase inhibitor like donazepam, or you can consider medication like memantine, right? And neuropsychiatric, if let's say there is, you should consider this and refer to psychiatry for assessment. And particularly this one, PIMA, when I didn't know about this anyway, pimavanserin is something that mentioned in the NHS leaflet. So I suppose we need to know also, but I don't think Malaysia we have this medication. But something additional that if let's say examiner asks. And then autonomic dysfunction, basically you're talking about bowel and urinary incontinence and also the autonomic hypotension, the orthostatic hypotension. So it's important for this patient got Parkinson already, gait may not be very steady, right? Also need to, if you got time, we do it all for all our geriatric patient. Is like counsel for family counseling, make sure that patient have fall prevention, all those things must be, I mean, the usual geriatric thing, the geriatric giant thing that we counsel. And let's say if patient have sleep disorder, REM sleep behavior is true, yes, memantine can help with the sleep. And sometimes low dose form of benzo as well as melatonin can help with the sleep as well. Okay. So yeah, one of the questions I want to clarify was the medication, can the symptom improve with these two? The answer is actually not, because Lewy body dementia will get worse with typical or even the classic antipsychotic. Risperdal and olanzapine are so-called atypical under the psychiatric medication, but they are in a way they are still kind of like the first generation of atypical, which is not very good because a lot of dirty side effect as well. And then can this be due to alcohol? Yes. Need breast scan? Yes, good, because when they rule out any the vascular dementia part, right? And this is just a brief outline on the young dementia. So remember, if you encounter any young dementia, this is the approach. The approach is to make sure you exclude delirium and depression and reversible causes. Only then you think about all this possibility. If it's really young already got vascular dementia, then you need to think about family history of stroke. And can this be CADASIL or CARASIL? Can this be cerebral amyloid angiopathy or vasculitis? So CAA is something like diagnostic exclusion. So we don't routinely mention that. But if you are giving vascular dementia as a differential, then yes, you can mention that. And then hereditary form of dementia can present early, which include Huntington, Wilson, and SCA. That's why we need to screen. And that's also important to screen for liver kind of symptom, because other than knowing alcoholic or not, which will leads to the Wernicke-Korsakoff, also important for us not to miss the Wilson, which can present as the, the extrapyramidal, the choretic movement and all those things. And the third thing for us important is to offer the diagnosis of normal pressure hydrocephalus as well, because it can present early. And Lewy body dementia, like this scenario, encephalitis, whether it's autoimmune or infective. So I also realized that you didn't ask about any episode of fitting for this patient, right?
Yeah, I did ask.
Yeah, it's also quite important when we screen through the neurological symptom, other than the rush stroke lah. So we also need to make sure we not dealing with something like a seizure. Another thing is, Wernicke-Korsakoff we have mentioned, and then the last one is Alzheimer lah. Alzheimer, we know that nowadays Alzheimer got genetic form of Alzheimer, hereditary form of Alzheimer, got certain genes lah. So those Alzheimer can present early. They are young onset Alzheimer disease. With that, I think that's all for the today's session. Anyone have any question? Eldon, you have any question to ask?
No, so far okay. Thanks.
Okay, right. I think your performance is considered good already. It's really good. You know what to examine. Just that I think to do a MOCA or MMS is a bit not practical in real exam, because examination you only got like 3 minutes to 4 minutes to examine the patient. So you need to save your time to get the highest yield of the calibration. That if you should always think like that when you go for exam, right? If you are the examiner, what are the things that you want to calibrate for this scenario? Are you going to calibrate for MMSC? Definitely not, right? Even the examiner, when they calibrate the patient, only use the 5-minute chin chai ask as the circuit, okay, this and that, examine or got sign, then okay already. So imagine that they are actually using 5 to 10 minutes to calibrate the patient. They will not do anything that is lengthy, and they will not do anything that is difficult to elicit. And the sign must be consistent with every patient. So that's why if you think about from this perspective, you will realize that examiner tends to calibrate things that is easy to elicit and must be something that expected from us lah. So if you think from this perspective, then you will realize that for this patient, definitely you will check the gait. And for this patient, maybe because the dementia one, you may want to just screen for the orientation part, time, place, and person. And then the gait, other than the gait neurologic examination, you want to do the extrapyramidal one, which is a Parkinsonism, and also a cerebellum. Probably the examiner will just calibrate as such. They will not calibrate anything more than that. Okay? So if you think like that, then it is safe that you elicit all these things. So let's say back to the scenario again. Patient progressive memory decline. When you prepare a scenario outside, you should try to gauge what are the things that examiner will try to calibrate, and what are the things that you want to examine. So it's also important for you when you write outside, not just the history and the differential diagnosis. If you got time, you should write a bit on the investigation and also the examination. So for this, if you look at this, you know that okay, I need to do some neuro. Okay, this maybe got some Parkinson or cerebellum, or don't know when to rule out all this. So you must write in your paper outside so that you don't forget it. And if you go focus examination, then you will able to get all the sign that the examiner calibrated lah. That will be the I think that will be the easier way to really score the exam. Okay. If anyone got no question, we'll end the session for today. Thank you everyone for joining. I know it's a very busy weekend. Most of us also most of the people cannot join today. Got some mock exam and a lot of courses. And also some already entering into exam mode, don't want to talk to anyone already. So I hope I may not have any session for October until the end of October. We will see how it goes. But I hope those that are going for exam in the mid-October, all the best to everyone. Okay? Alright, I'm going to stop the recording. If any question you all can still ask in the group. Alright. Okay, you all can leave